Evergreen. कैमरा वाला कौन इनको साइड में करते बेटा 5 मिनट 7 लोग बैठे
तो फिर लाइन जाएगा तो कैसे जाएगा सर बस एक एंट्री होगी उसके बाद ये
पहले हटाना साइड कर दो ना फिलहाल के लिए साइड कर दो बाद में
move forward, I extend my warm welcome to our distinguished guests and call upon them on stage. With this, first of all, I invite our Chief Guest, Shri Ujjwal Tasar, Director General of Mine Safety. I request Shri Manish Jaiswal Sir, DGMS Ahmedabad Region 1, to escort please Ujjwal Tasar. In this, I request MD Mishra Sir, DGMS Surat Region, to welcome Shri R.T. Mandekar Sir, Deputy Director General Mine Safety, DGMS Northwest Zone. In this, I request Sri C. Pannamalai Sahab, DMS Electrical Northwest Zone, to please welcome and escort Shri Bhagwati Prasad Sahab, IAS, DMG, Government of Rajasthan. With this, I request Shri B. Dayasagar Sahab, DMS Udaipur Region, to escort Shri Arun Mishra Sir, CEO, SZL. I request J.P. Verma Sir, DMS Mechanical Northwest Zone, to escort Mangilal Lunawat, President UCCI Udaipur. And in this, I request Surjit Kateva Sir, DMS Ajmer Region 1, to welcome Shri Kaushik Sarkar Sir, Inspector of Mine, Occupational Health, DGMS. I request all to please stand up for the national anthem. Now to have a warm welcome to our dignitaries, I request Deputy Director General Mine Safety, Shri R.T. Mandekar Sir, to welcome our chief guest of the day, Shri Ujjwal Das Sir, Director General Mine Safety, with a flower bouquet and a uparna. I request R.T. Mandekar Sir to welcome Bhagwati Prasad Sir, IAS DMG, Government of Rajasthan. I request Mandekar Sir to welcome Shri Arun Mishra Sir, CEO, SZL. I request Mandekar Sir to welcome Shri Mangilal Lunawat, President UCCI Udaipur. Thank you, Mandekar Sir. Now I request B. Dayasagar Sir, Director Mine Safety Udaipur, to welcome Shri R.T. Mandekar Sir, Deputy Director General Mine Safety, Northwest Zone. In the continuation, I request Dayasagar Sir to welcome Shri Kaushik Sarkar Sir, Inspector of Mine, Occupational Health, DGMS. थैंक यू सर। इस कड़ी में आगे बढ़ते हुए मैं सभी डिग्निटरी से रिक्वेस्ट करता हूं कि वे दीप प्रज्वलन कर आज के इस वर्कशॉप के इनॉग्रेशन करें। I would like to invite Shri R.T. Mandekar sir, Deputy Director General Mine Safety, to deliver the welcome address and set the tone for today's deliberations.
सभी को मेरा नमस्कार। वक्त को ध्यान में रखते हुए मैं अपनी बात को शॉर्ट में रखूंगा। मैं दिल के गहराई से हमारे डायरेक्टर जनरल साहब उज्ज्वल साहब को धन्यवाद करना चाहता हूँ और वेलकम करता हूँ कि उन्होंने हमको ये अपॉर्चुनिटी दी कि इस सेंसिटिव टॉपिक पे जो कई दिनों से इसके ऊपर चर्चा होने पर कुछ कॉन्क्रीट नहीं कर पा रहे थे, तो हमको प्रेरणा दी और आज के फंक्शन में वो स्वतः उपस्थित हुए अपने बिजी शेड्यूल के बाद। तो आई एक्सटेंड माई हार्टली वेलकम टू दिस। आई ऑल्सो एक्सटेंड माई हार्टली वेलकम टू श्री भगवती प्रसाद साहब, जिन्होंने हमारे एक रिक्वेस्ट पे आप जानते हैं कितना बिजी शेड्यूल उनका है, डीएमजी है वो और आरएसएमएम का भी चार्ज उनके पास है। उसके बावजूद भी इतने बिजी रहने के बाद भी उन्होंने एक अच्छे कॉज के लिए अपना समय दिया, उसके लिए मैं उनके दिल की गहराई से वेलकम करता हूँ, स्वागत करता हूँ। अरुण मिश्रा साहब, हिंदुस्तान जी हमारी स्ट्रेंथ रहे, इस एरिया में कोई भी कार्यक्रम करना हो, कुछ करना हो, अगर हम उनको एक कॉल करते हैं तो वो एक पैर पे खड़े रहते। आज सुबह ही वो सीधे लैंड किए हैं, बाहर से आए और सीधे आ गए, घर भी नहीं गए वो। सो उनका मैं बहुत तहे दिल से स्वागत करता हूँ। मांगेलाल गुनावत जी, ये भी एक ऐसी शख्सियत है, दिखते ओल्ड है लेकिन बहुत यंग है, और उनको एक बात बोल दो कोई कि सर हमको ये ऐसे करना है, वो एकदम सामने आके सुबह शाम फोन करते हैं उनको और कोई भी हेल्प के लिए तैयार रहते हैं। और वो अपने माइंस के लिए, माइंस ओनर्स के लिए, माइनिंग फ्रेटर्निटी के लिए फाइट करने के लिए, लड़ने के लिए हरदम तैयार रहते हैं। तो उनका भी मैं बहुत तहे दिल से स्वागत करता हूँ। डॉक्टर सरकार हमारे साथी डीजीएमएस के, जो ऑक्यूपेशनल हेल्थ सर्विसेज को देखते हैं डीजीएमएस की तरफ से, उन्होंने इस वर्कशॉप को ऑर्गेनाइज करने के लिए बहुत मेहनत करी, हमारा बहुत गाइडेंस किया और सारी परिकल्पना डीजी साहब के साथ बैठने उनके, और आज 3 दिन से उदयपुर में उपस्थित है ये पूरे चीजों को संभालने के लिए, उनका भी बहुत तहे दिल से स्वागत करता हूँ। मैं सभी पार्टिसिपेंट्स जो वेरियस ऑर्गेनाइजेशन, कोल सेक्टर, ऑयल सेक्टर, मेटल माइन सेक्टर से यहाँ पर है, स्पेसिफिकली डॉक्टर्स, बहुत संख्या में हमको बहुत अच्छा तगड़ा रिस्पांस मिला। हमारा यहाँ जो है पैन इंडिया प्रेजेंस है, पैन कंपनी, सारी कंपनी, कोल की सारी कंपनी को हमने टच करने का कोशिश किया, जितना हमको हमारे पास ये था, नॉलेज था, हमने सारे लोगों को टच करने का। और हमको पार्टिसिपेशन भी 24 दिसंबर उदयपुर का बहुत टूरिस्ट डेस्टिनेशन होने की वजह से बड़ा कैपेसिटी फुल रहता है हर जगह, लेकिन उसके बाद भी इतना पार्टिसिपेशन, इतना रिस्पांस हमको मिला, उसके लिए सारे पार्टिसिपेंट्स इंक्लूडिंग डॉक्टर्स, मैनेजर्स, एजेंट्स, ओनर्स, सबका तहे दिल से स्वागत है। स्टेट गवर्नमेंट ऑफिशियल्स, हमने डीएमजी से ऑफिशियल्स, हमने चीफ मेडिकल हेल्थ ऑफिसर्स कई डिस्ट्रिक्ट के हमने इनवाइट किए, उनके तरफ से भी बहुत अच्छा हमको रिस्पांस मिला। स्टेट गवर्नमेंट की तरफ से जो भी अधिकारी यहाँ उपस्थित है उनका भी बहुत बहुत स्वागत है, बहुत बहुत धन्यवाद साहब, आप लोग हमको समय दे रहे, थैंक यू वेरी मच। ऑफिशियल्स ऑफ द अदर वर्टिकल्स ऑफ मिनिस्ट्री ऑफ लेबर एंड एम्प्लॉयमेंट गवर्नमेंट ऑफ इंडिया, जैसे ईएसआईसी, ईपीएफओ, सीएलसी और डीजीएमडब्ल्यू, इनके भी ऑफिसर्स हमारे बीच में उपस्थित है। उनको भी हमने सिर्फ एक कॉल किया, एक छोटा सा, उन्होंने तुरंत अपना पार्टिसिपेशन इसमें किया, क्योंकि हम इसको पैन इंडिया बनाना चाहते थे, अक्रॉस ऑल बनाना चाहते थे हम, इसलिए उन्होंने भी अपने पार्टिसिपेंट्स को यहाँ भेजा है डेलीगेट्स के रूप में, उनका भी बहुत बहुत तहे दिल से। और ईएसआईसी का तो स्पीकर भी रहेंगे यहाँ पर, तो उनका भी तहे दिल से स्वागत है। ट्रेड यूनियन रिप्रेजेंटेटिव्स जो यहाँ उपस्थित है उनका भी स्वागत है, और सभी लोग इसको सक्सेस करने में अपना डायरेक्ट और इनडायरेक्ट सहयोग दे रहे हैं, जिसमें काफी कंपनियां हैं, हिंदुस्तान जिंक है, श्री सीमेंट है, जेके सीमेंट है, जेके लक्ष्मी सीमेंट है, बिरला कार्टून, बहुत सारे लोगों ने हमको इसको ऑर्गेनाइजिंग करने में सहयोग किया और उन्होंने अपना पार्टिसिपेशन दिया, और वो लोग पिछले 1 हफ्ते से लगातार इसको सक्सेस करने में लगे, सबका तहे दिल से स्वागत है। और प्रेस एंड मीडिया के हमारे साथी जो यहाँ उपस्थित है, उनका भी स्वागत है। और कोई अगर लेफ्ट आउट हो रहेगा होगा तो माफी चाहता हूँ, समय की कमी की वजह से नाम नहीं बोल पा रहा हूँ, तो सबका एक बार फिर से स्वागत है। थैंक यू।
Thank you, sir. Now I request Shri Kaushik Sarkar, sir, Inspector of Mines, Occupational Health, who has played a pivotal role, especially in organization and execution of this seminar's technical aspect.
Thank you, sir. Good morning to you all. Very warm welcome. Respected Chief Guest of today's workshop, our beloved DG sir, Shri Ujjwal sir. Guest of honors, Bhagavati Prasad Kallal, IAS, DMG sir. Arun Mishra sir from SZL, Runawat sir from UCCI. हमारे नॉर्थ वेस्टर्न जोन की डिप्टी डीजी श्री मांडेकर साहब, all other dignitaries, mine owners from different mines across the country, speakers, delegates, members and representatives of the trade union, representatives of the press and electronic media, ladies and gentlemen. On this occasion, I take the proud privilege to rise before you to deliver the keynote address for this workshop. It is definitely an honor for me. India, with a population of roughly 1.3 million, 3 billion and above, has got a workforce of about 425 million and an employable workforce of around 580 million, as per the latest data. Out of that, roughly about 1.3 million people work in the mining and quarrying industries. The extraction of minerals from earth involves working under unnatural conditions, dark, dusty, hot, humid, noisy environment in underground. Mines adversely affect the health of the workers. Noise, vibration, etc. cause serious occupational health problems like NIHL, heat stroke, vibrational syndrome in both underground as well as open dust mines. Working in the dust environment may cause respiratory disorders like interstitial lung diseases, allergic bronchitis, occupational asthma, etc. Poisoning due to inhalation of metal dust such as manganese cause serious occupational health disorder like manganese poisoning. I think we have a session on manganese poisoning today. Working in inadequate light may cause serious eye problems like minus nystagmus. The nature of job in mining is quite hazardous and painstaking. The workers are always vulnerable to be affected by the various hazards during their day-to-day working. In the last decades, there have been a sea changes in the economic, political and technological environment of the world, especially in the developing countries like ours. In this context, new challenges have been bestowed upon most of the core industries, including mining industries as a whole. These challenges are mainly multifactorial. Firstly, to meet the soaring demands of the minerals within the country and for development as well as for export, has forced the industries to go for heavy mechanization and modernization of mining equipment. This resulted in sea changes in the pattern of health hazards that the miners face in their day-to-day mining activities. Nextly, to make mineral production more profitable, outsourcing of non-core as well as core activities of mining become an order of the day. This also resulted in the engagement of inadequately trained manpower across the whole category of mines who are much more vulnerable to all kinds of hazards. Today the miners, at least in the organized sectors, suffer from the disease caused by the in the organized sector, of these mining and oil companies do not conduct proper hygiene monitoring survey regularly and do not identify and quantify various health hazards. Occupational health centers amongst unorganized sectors and small sector mines are still extremely discouraging. Awareness level amongst both employees as well as employers is pathetic. Most of these units do neither have a full-time, even part-time medical officer qualified trained in occupational health or ILO classification of such radiograph, nor they have access to any fully equipped occupational health center and health diagnostic facilities. Some of them only have some arrangements with the state governments to take care of day-to-day healthcare need. The overall compliance rate in the unorganized sectors, both in terms of statutory medical surveillance and notification of notified disease, is extremely low and below 30%. In regards to notified disease, there is always a considerable variation in number of cases of notified disease detected in various mines due to improper medical examination and surveillance. In large mining sectors, the scenario is better. Cases like disease, like coal workers, pneumoconiosis, silicosis, occupational malignancies, noise-induced hearing loss are reported time to time, even though the numbers are far below the actuals. In small and unorganized mines, there are hardly any cases detected and reported by the mine management of their own due to severe lack of expertise and inaccessibility to the diagnostic facilities. The real situation in the small mines come to the surface only during any occupational health survey conducted by either the enforcement agencies or by any scientific organizations. So far, smaller and unorganized units have not reported a single case of notified disease on their own. The exact cause of this scenario is highly complex and multifactorial. Due to lack of awareness in our society regarding the health, even the percentage of money spent on GDP on health is as meager as only 2%. In comparison to the developing countries, which varies from 10 to 16%. Facilities of structured training in industrial and occupational medicine and ILO classification of chest X-rays is extremely inadequate in our countries. That creates a big problem in proper diagnosing and detecting the occupational disease, especially in the unorganized sectors. Like many countries, in our country also safety and health are dead side by side under the same statute. Due to extreme lack of awareness amongst all sections of the society, health always takes a back seat in comparison to the safety. As effect of health hazards takes at least 5 to 10 years to produce its symptoms amongst persons exposed to, whereas suffering from the large number of persons at a time, unlike safety hazard causing urgent and immediate danger of life and properties. Finally, it is worth to impress upon that a logical and systematic approach towards working in an industry is the first step towards the better maintenance
आज के कार्यक्रम के मुख्य अतिथि डायरेक्टर जनरल ऑफ माइन सेफ्टी श्रीमान उज्ज्वल जी साहब, आदरणीय नॉर्थ वेस्ट जोन के डिप्टी डायरेक्टर जनरल ऑफ माइन सेफ्टी श्रीमान आर.टी. मांडेकर साहब, खान एवं भू विज्ञान विभाग के निर्देशक श्रीमान भगवती प्रसाद जी कलाल साहब, हिंदुस्तान जी के CEO श्रीमान अरुण मिश्रा जी साहब, इंस्पेक्टर ऑफ माइंस ओएस डॉक्टर कौशिक सरकार जी, माइनिंग डिपार्टमेंट के प्रधान सभी अधिकारीगण, इंडियन ब्यूरो ऑफ माइंस के सभी अधिकारीगण, आज के कार्यक्रम में उपस्थित प्रदेश की विभिन्न औद्योगिक एवं व्यावसायिक इकाइयों के लिए अधिग्रहण विभिन्न सरकारी विभागों से पधारे अधिकारीगण, पधारे हुए UCCI के सम्मानित सदस्य तथा प्रेस एवं मीडिया के पधारे प्रतिनिधि, मेरे लिए आज डायरेक्टर जनरल ऑफ माइन सेफ्टी श्रीमान उज्ज्वल साहब का UCCI में स्वागत करना अत्यंत गर्व एवं प्रसन्नता की बात है। मैं आप सभी को इस कार्यक्रम में पधारने के लिए UCCI की ओर से हार्दिक स्वागत एवं आभार व्यक्त करता हूँ। इस अवसर पर आप सब महानुभाव को UCCI की कार्यकाल के संक्षिप्त जानकारी देना चाहता हूँ। UCCI दक्षिण राजस्थान की उद्योग, व्यवसाय, शिक्षा, पर्यटन एवं खनन की प्रतिनिधि संस्था है। आज UCCI में लगभग 570 डायरेक्ट सदस्य हैं और 1500 से ज्यादा एसोसिएट सदस्य हैं, क्योंकि बहुत सारे एसोसिएशन जो है UCCI के सदस्य हैं। भारत सरकार द्वारा उदयपुर चैम्बर ऑफ कॉमर्स को निर्यातकों को सर्टिफिकेट ऑफ ऑपरेशन जारी करने के लिए अधिकृत किया हुआ है। जितने भी एक्सपोर्ट के लिए जो डॉक्यूमेंट होते हैं उसके सर्टिफिकेशन UCCI करती है। चैम्बर द्वारा निर्यात बिलों का सत्यापन तथा व्यापारिक वीजा जारी करने के लिए आग्रह पत्र की सेवाएं भी जारी है। उदयपुर चैम्बर को लगभग सभी जिला स्तरीय, राज्य स्तरीय, राष्ट्रीय सलाहकार समितियां के प्रतिनिधि प्राप्त है। चैम्बर द्वारा राज्य सरकार एवं केंद्र सरकार को नीति निर्धारण कमेटियां के समय पर व्यापारिक समुदाय के दृष्टि से अवगत कराया जाता है। UCCI द्वारा गुडली के निकट हानिकारक अपशिष्ट के उपचार और निस्तारण हेतु एक हानिकारक अपशिष्ट प्रबंधन सुविधा का संचालन किया गया है, तो राजस्थान में साउथ जोन, नॉर्थ जोन के अंदर सेकंड ओनली है जिसका इसका हानिकारक अपशिष्ट जो होते हैं उसके लिए किया जाता है, जिसमें लगभग 1850 से अधिक औद्योगिक इकाई सुविधा से लाभान्वित की जा रही है। आपको यह जानकर प्रसन्नता होगी कि UCCI द्वारा वोकेशनल ट्रेनिंग सेंटर के माध्यम से माइनिंग मेड और माइनिंग इलेक्ट्रीशियन पर ट्रेनिंग कोर्स का संचालन भी किया जा रहा है। यह कोर्स NCVET नेशनल काउंसिल ऑफ वोकेशनल एजुकेशन एंड ट्रेनिंग द्वारा NSDC नेशनल स्किल डेवलपमेंट काउंसिल द्वारा संचालित की PMKY 40 प्रधानमंत्री कौशल विकास योजना के तहत कौशल विकास मंत्रालय द्वारा वर्ष 2024-25 के लिए UCCI को आवंटित किए गए हैं। वर्तमान में एक बैच माइनिंग इलेक्शन और माइनिंग मेज का बैच PTC संचालित है और इस मार्च तक का टारगेट 1000 आदमियों को ट्रेनिंग देना और उनको संचालित करने के लिए प्रावधान किया हुआ है। इस अवसर पर आदरणीय मुख्य अतिथि महोदय को भी अवगत कराना चाहता हूँ कि पिछले 40 वर्षों के दौरान माइन सेफ्टी डिपार्टमेंट द्वारा माइन ऑनर्स को पूरा सहयोग प्रदान किया है। मेरे पर्सनल रूप से सबसे गत 40 वर्षों से परिचय है और उसमें जो सहयोग जितने भी लोकल ऑफिसर DDG और दूसरे ऑफिसर डायरेक्टर से लेवल के रहते हैं, उनका पूरा सहयोग छोटे छोटे माइन को भी, ये एरिया पूरा 5 माइनिंग एरिया है, लार्ज स्केल की माइन से लिमिटेड है, लेकिन छोटी माइनों के लिए तो उनका सपोर्ट जो है लोकल ऑफिसर्स का सपोर्ट पूरा रहा। इस अंजाने कई बार अंजाने में छोटे माइन होने के लिए अनुपालन में किसी प्रकार की कमी रह जाती है, वो उनको एजुकेट करते हैं कि ये कमी रह गई, इसको आप ठीक करो। ये नहीं कि उन्होंने प्रोसिक्यूट का लेटर दे दिया, हमेशा ये गए तो उन्होंने हमेशा एडवाइस करी कि ये चीज़ें को आप संभाल के रखो कि ये चीज़ कमी है, इसको ठीक करो। मतलब ये नहीं है कि उन्होंने नोटिस जारी कर दिया। जितने ऑफिसर मेरे सौभाग्यशाली हूँ और मैं गर्व से कह सकता हूँ कि उदयपुर जोन में जो डॉक्टर लेवल के आदमी जो यहाँ पर भेजे हैं वो एक से एक बढ़कर अच्छे रहे और जो छोटी इंडस्ट्रीज को, छोटी माइनिंग को सपोर्ट करके उन्होंने इतना अच्छा काम किया जो हम आपको बता नहीं सकते। जो स्टाफ यहाँ पर डेपुटेड है वो बाकी स्टाफ भी सब ऐसे कोऑपरेटिव है, जो छोटी छोटी माइनिंग के लिए वो जितना सपोर्ट कर सकते हैं वो पूरा कर रहे हैं। आज इस कार्यक्रम के संदर्भ में कहना चाहता हूँ, मंच पर कार्यरत स्टाफ के लिए इस प्रकार की जागरूकता एवं प्रशिक्षण कार्यक्रम का आयोजन आज के संदर्भ में बहुत ही उपयोगी सिद्ध हो सकता है। माइनिंग से जुड़े श्रमिक एवं स्टाफ को पर्याप्त सावधानी कार्य करने के प्रधान सत्र प्रदान किए जाने की आवश्यकता है। ये जीरो एक्सीडेंट जो प्रक्रिया है, इसे साउथ आसाम के अंदर जो ऑलमोस्ट जीरो एक्सीडेंट ही है। जहाँ लाखों आदमी कार्यरत हैं, उसमें एक आध एक्सीडेंट होना मामूली बात है, लेकिन सेफ्टी का पूरा प्रोफेशन रखते हुए और बीमारी किसी भी तरह की बीमारी के लिए ध्यान रखते हुए सब लोग पूरे जितने माइंस ऑर्डर हैं और जितने यहाँ के आदमी हैं वो सब हमारा सपोर्ट करते हैं। बीसीसीआई को यह भी प्रयास है कि चैम्बर के सदस्यों द्वारा खनन उद्यमों DGMS के अधिकारियों के माध्यम विचार विनिमय हेतु नियमित अंतर्वाल पर डिस्कशन होते रहते हैं। मैं आशा करता हूँ कि आज का कार्यक्रम सभी प्रतिभागियों के लिए उपयोगी सिद्ध होगा। इस आशा के साथ मैं आप सभी का आज के इस कार्यक्रम में ज़्यादा से ज़्यादा लाभ लेने के लिए धन्यवाद देता हूँ। और आपने यहाँ बाहर से पढ़ा है, आपने समय निकाला, इसके लिए आपका बहुत बहुत धन्यवाद।
Thank you, Ronald sir. Now I request Shri Arun Mishra sir, CEO SZL, to come forward and address us.
Good morning. Today's chief guest, Sri Ujjwal Kasha, Director General DGMS. Guest of honor, Sri Bhagwati Prasad Kalal sir, IAS, Director DMG. Sri R.T. Mandekar sir, DG Northwest Region. Dr. Kaushik Sarkar, Inspector Occupational Health Services DGMS. Sri Mangila Lunavarji, President UCCI, members of print and electronic media, all company and industry representatives. It's always heartening, especially for someone who has been in the mining industry for more than 32 years, and especially in this zone where world's one of the largest underground mines and also world's most famous marble mines, most famous dolomite mines, and all other small and large mines are located. It is very pertinent that we discuss about occupational health in such a region. Saying that, I would also like to put on record that many of the things about mining and occupational health is born out of perception, miscommunication, as well as some due to genuine bona fide reasons. Accidents on the road are easily visible, latest being the Jaipur-Ajmer road, where with the gas leakage and corresponding inflammation of gas killed some 14 people. But we don't stop that road even for half an hour. When the railway accident happens and 100 people die, the railway line, the focus of the nation is how quickly the railway line will restart. Whereas in a mine, if something happens, whole nation turns against mining, as if we are the only one to be blamed, while we are the ones who have been developing the nation. If I look at some of the figures, till 2022, when the occupational health system became online, records are available, I think total number of deaths due to silicosis in India has been about 30,000 odd. Whereas in 2021, in 1 year, 1,55,000 people died on the road. So while this is an important subject and we must do whatever is required, but also it's time for us to communicate. It's not all that bad the way we perceive it to be. The provisions of the Government of India and of course from Director General Mine Safety wise are extremely strong. They are extremely watchful. Of course there are scales of mines who can afford and who cannot afford. Perhaps that is where we have to have some brainstorming. If it is possible, I have seen in China that where there are small MSMEs are operating, government controlled common research center, common marketing center is available, which everybody pays their subscription, and that common center like in Shenzhen, entire LED business of China, there is a common R&D center who develop LED and give that to MSMEs. All the new LEDs that you see are developed in one common place where MSMEs pay subscription, and hence any new LED finding is given equally to all MSMEs to produce. Similarly, if we can have similar such concept for mines of a particular size, for each one of whom it will be very difficult to individually put up all occupational health centers of the latest requirement and all that. If we have a standard, centralized, even if it is privately operated occupational health center where everybody subscribes to, and they actually bring in the latest, whether it is diagnostic, whether it is curative, preventive methodologies for miners to adopt. Whereas of course large miners like us and Hindustan Zinc and others, of course they have to do their own. So I don't think a company like ours, with the money that we make, we should be developing, we should be having best practice of our own. But even there are small miners or MSMEs, they should have a common pool where they can subscribe to. That may change the perception at least that yes, each individual worker gets equal amount of facility, whether the worker works in a small mine or a large mine. So that is something that we can work out. At the same time, metal mining by itself is hazardous, and that too when we are mining metals which are also associated with many heavy metals. All of them do not have equal impact on the health, and we have to be extremely watchful. And that also should be thought of when we are auctioning of mines. That also need to be taken care of. That the bidders who come, do they have qualification? Can they really put up such facilities? Because it's just not auction or money. The mineral conservation rule has to be applied. The safety measures have to be applied. Company must have a background of proven safety records. The occupational health systems to be established. Otherwise, what we are seeing is, okay, come to auction, bid whatever you can, but then either you don't operate the mine. If you operate the mine, then these facilities will be crying, and that is what is also equally more important. So while auctioning is mandatory, we must do, also build a criteria that companies with proven record and companies who have the ability, have the knowledge, have the HR pool who can develop such facilities for the benefit of the workmen should also be encouraged. I think those are, I'm sure in the days today, whole day deliberation, many such points will come. And I'm extremely thankful to Tasa for selecting Udaipur as the place where to hold this, and Mandekar sir for carrying this out. This will go to the national media. The country would know that in Rajasthan and in Udaipur we are doing this, and we are doing this where DMG is located, which is actually the main planning and finding out body for government of Rajasthan. So I'm very fortunate to be part of it. And yes, Mandekar sir, we and especially me, being in mining for, although I'm electrical engineer, but being in mining for 32 years, always on your call. आप कभी भी बुलाएंगे क्या नहीं बोलते हैं, तो आना मेरा फर्ज है, because I love mining. Somebody who has taken up mining profession by choice, not by qualification. And इसके लिए मैंने पढ़ा भी हुआ, शरीर में mining नहीं पढ़ा. I went to do mining course in Australia, and that's how I became more. My mining friends do argue with me in meetings कि किसको कितना पता है, but nevertheless it's a fantastic profession, scientific profession. This profession generates wealth for people, and mining profession engages and employs people, and mining profession has all the rules to take care of safety and health of people. We should all be proud of this profession, and we should speak as much as possible about this profession, which is one of the best professions in India. Thank you so much.
Thank you, Mr. Sir. Now I request our guest of honor, Shri Bhagwati Prasad sir, IAS DMG, Government of Rajasthan, to address us.
Respected Director General, Mines and Subject, Sri Ujjwal sir, RT Mandekar sir, Deputy Director General of Mines, Safety Northwest Zone, Sri Arun Mishra ji, CEO Hindustan Zinc Limited, Sri Manganese Inaugural sir, President UCCI, Dr. Kaushik Sarkar, Inspector of Mines, Occupational Health, West Zone, distinguished guests, participants, friends and friends from media, ladies and gentlemen. Good morning to all of you. It gives me immense pleasure to share my thoughts on the subject in the one-day national workshop on occupational health services in mines current scenario, challenges and way forward. Organized by the esteemed Organization of Government of India, Directorate, Mines Safety. On behalf of Department of Mines and Geology, Rajasthan, I extend my heartfelt gratitude to all of you for joining in this important gathering. As we all know, the mining sector plays a crucial role in the economic development of our nation, contributing significantly to the growth of industries, infrastructure, and energy. In Rajasthan, our mineral wealth and mining activities have supported the nation's need in iron, limestone, rock phosphate, marble, and many other critical resources. However, with the enormous potential comes the responsibility of ensuring the health and safety of workforce engaged in these activities. This workshop focuses on one of the most critical aspects of mining, the occupational health of workers. While much attention is given to the technical, economic and environmental challenges of the mining sector, the health and well-being of those who work in mines must never be overlooked. It is imperative that we constantly address the emerging concerns and work towards providing a safe and healthy working environment of our mines. As far as Rajasthan is concerned, we have identified 22,000 silicosis patients. I have been Collector Sirohi also. The few of you must be knowing that the district is known for carving stone for the temples. When we talk of silicosis, a lot of people understand that silicosis is due to mining activities only. When we are today discussing on occupational health, one of the hazard is silicosis, yes. When we are talking about framing policies or framing a regulatory framework, then we must not forget the MSME dependent on minerals, because those will be located in the vicinity of mines where raw material is available. So any policy, any framework which is being enacted or prepared should look upon that aspect critically, so that a wholesome package for stopping the spread of silicosis may come out. I have seen the people who used to come to me for help, for oxygen cylinders, or for financial help, for medical help. You see the person dying in front of you, it is very painful. There are also other occupational health hazards, as Dr. Kaushik Sharkar has mentioned. So I'll put Rajasthan's few statistics in that perspective. In Rajasthan, the mining industry is diverse and spans a range of activities from large-scale commercial operations to smaller artisanal mining. In Rajasthan, we have about 150 major mining leases and 70,000 mining leases of minor minerals and more than 17,000 quarry licenses of minor minerals. About 40 lakhs of people get direct or indirect employment in mineral sector in this state. Most of the workforce in these mines often faces harsh and hazardous conditions. These include exposure to dust, fumes, noise and physical strain. The prevalent health issues are manifold: respiratory diseases, musculoskeletal disorder, noise-induced hearing loss and psychological stress. Despite advancements in safety protocols and health surveillance system, we continue to witness a worrying incidence of occupational health disease in the mining sector. While we have made significant strides in improving safety through training, regulations, and the adoption of better technologies, the health risks associated with mining remains pressing challenges. We face challenges because there is a lack of awareness among the workers itself. When we were in the field, we used to organize medical camps for the workers. Mine owners or government used to distribute dust masks or gloves or some safety equipment. They don't wear regularly basically. when we used to talk to mine owners, why don't you force them to wear all those safety equipments or use all the precautions as mentioned by the Director Mines and Safety. So this was not in habit. Now the responsibility is on the shoulders of the mine owners. We should strive to achieve the target of a scenario where all mine workers are adopting hazardous-free work environment. They are well equipped with all the safety equipments. Wherever mine worker does not adopt any precaution mentioned by the authorities, they should not be employed. By the threat of losing job opportunity, definitely he will adopt or he will wear all the safety equipments. But that is not done. This is where we all have to work. We have to put pressure, some kind of pressure should be put on the mine workers because they don't need the job and we need the safety. Because they are not aware, so awareness is lacking among the mine workers as well as few mine owners also who are working on a small scale. We have got inadequate health infrastructure also when it comes to mines because all health facilities are situated at distance from the mines. So there comes the role of DMT funds because a lot of contribution comes from the mines for the welfare of the people affected by mining activities. We should strive for a policy where health checkups should be regularly done as well as some mechanism should be developed so some fixed portion of the DMF fund should contribute the welfare and well-being of the mine workers. That fund is managed by the district administration and most of the time the focus is on the welfare activities like construction of the schools, health facilities or drinking facilities. So somewhere the medical well-being or health well-being of mine workers is left out or not focused that much. So that is the area where we are lacking. There is a limited access to specialized care. I have seen people with silicosis. So if one is identified with silicosis, then there is nobody to take care of that. We just discussed, could not complete the project, but discussed to supplying oxygen cylinder at their home at free of cost because they are just about to die. Nobody can do nothing. You are seeing them dying day by day, every second. So there should be specialized care in those cases. Regulatory or enforcement gaps are there. Yes, there are few people in the industry also who don't follow the regulations and framework. There are psychological health issues which as a society, as a whole, in India we ignore. That is a social stigma in case we are identified with psychological issues, so that needs to be addressed. So we have to work on all the challenges and by working upon the challenges we can overcome the occupational health hazards of the mining industry. As we embark on today's discussion, I urge each one of you to contribute your valuable insights and experience to help us shape a future where the health and safety of miners is given the utmost priority. The challenges we face are significant, but they are not insurmountable. Together, through concerted efforts, innovation and collaboration, we can create a mining environment that is not only productive but also safe and healthy for all. I extend my deepest gratitude to the Director General Mine Safety and the organizing team of DGMS Udaipur for bringing together experts, practitioners and stakeholders to address these critical issues. I am confident that this workshop will provide valuable guidance and actionable solutions to improve the occupational health services in mines across the country. Once again, I welcome all of you to this workshop and I look forward to productive and enlightening discussions ahead. Thank you. Jai Hind.
Thank you, Balaji Prasad sir. As we all know that Ujjwal sir is the guiding force behind all these workshops being organized by the DGMS. So now I request Ujjwal sir, Director General Mine Safety, to address us and give his valuable insights for the today's day-long technical sessions.
Good morning, everybody. In the participants and everybody, we are present here in the city of lakes. It is a very pleasant place, pleasant environment. We cordially again welcome you all on behalf of Northwestern Zone, DGMS, Directorate DGMS, Shri Manganese sir and his team has done a very good job, commendable job. And this is the first time I think such workshop is being held in Udaipur on the subject matter of occupational health, which is a very much need of the hour. Dignitaries, my due respect to the dignitaries present in the dais and of the dais, different participants, and my dear present colleagues and ex-colleagues, and my different persons, doctors, particularly Dr. Commemorative, presents from different mining producing companies, particularly doctors from different verticals of the Ministry of Labour and Employment, particularly SIC and DG Facility and DGLW and other mining community like IBM. This is my privilege to be present among you this occupational health workshop. I think due to time's constraint, only one day workshop has been organized, but I think it will be a very much such a deep, vast subject that only with this time zone, how we will be doing, there are a number of papers will be discussed. This occupational health survey, I see that there are two dimensions, organized sector perception and unorganized sector perception. In organized sectors we see there are very facilities and doctors, but not much reporting cases. But when our doctors go and check, there are some cases being reported. They are finding some particularly many cases are being identified. Then that means either there is a case of proper infrastructure or training on the part of the doctors to detect that cases, or there are some other dimension that it is not being reported up. And for unorganized sector, this is a very big challenge for us to reach those people. Particularly, we do not know the dimension of their problem. We do not know how many persons are exposed. This is a very big challenge in the national level. And all the ministry verticals of my Ministry of Labour and they try hard to reach this unorganized sector. Then each state that problem, particularly not only from mining, from crushing, from carving, from pottery, and their exposure limit is so high, so we do not have proper estimate how many people are suffering, what is the level of their suffering, and how to mitigate the measures. You see, now these small sectors, why they are not able to do, they are justifiable causes. Because the mines are so small, their tenure is so less, and their shape of the leaves is so irregular and small, they cannot quantify, because compliance of this condition has a cost. This is not cost effective for the existing law. The small, I do not blame at all to the small mine management. There should be some protocol for issuing of leave. If we go to the root cause of the problem, it is that because the small mines are causing very problem, because it is not that they are doing deliberately. It is not scientifically possible to mine with the small lease and to economically exploit the mineral within such a small tenure and irregular shape. So there is a root root cause. So how to address the root cause? We have to, if we do not eliminate the root cause, our society, particularly this mining fraternity and community where the mines are located, this will be caused suffering to exist. Because there are maximum pollution level, maximum health issues, but it is neither detected nor monitored. Let it be in other cases of how to compensate those people. So what is the solution? Solution lies there in Mines Act. There are provisions. The joint construction of facilities for PME IME center for screening and for training joint group vocational training centers. Another solution that you will see a big lease with long term and good shape and not adjacent very close to the human population. And if the mineral exists there, then we have to take a concrete policy to rehabilitate those habitats so that proper mining can be conducted in scientific and systematic manner, complying with the previous provisions of the law of the land to mitigate this problem. Another occupational problem is there are two dimensions. One is workplace surveillance and another is workers' health surveillance. Where workplace surveillance mitigates the preventive measures and take control of the measures, workers' health surveillance it augurs for the present early detection of the patient of the stage of their health issues. Though occupational hour at present we legislation have at least 5 years at the joining it initial medical examination and every 5 years periodical medical examination, and after 45 years it is every year 3 years. Now in the present law we are Occupational Safety Health Working Condition Code. This is which is in the pipeline for the modification. It assures that every year every person's health should be screened. Then another thing, because very much important, our country Prime Minister also says that his priority is that Sabka Saath Sabka Vikas. That's inclusiveness. If we left behind this unorganized sector, vast populations of mine employees and the owners, then this is going, we are not giving proper attention to this, our Prime Minister's call. So we have to take a call on the matter. Another issue that developed, you see, our country was underdeveloped before independence. Now we are developing country. Our government has a vision to have developed country, that is Viksit Bharat by 2047. In the same line, India government have the policy towards that zero harm. Zero harm means not only accident, but also this zero health issues, zero occupational health disease. And occupational disease always we know, anything, the prevention is better than cure. But in the case of occupational disease, it has no cure. This is the biggest challenge for us. And if let it be cured, you treat this dust as a silent killer. So we do not know what is affecting after advanced stage. If it is detected, there is no possibility of curing that patient. So it is the biggest challenge. That early detection only is the problem, our concern. And main issue should be, our first area should be prevention. So as the preventive measures, we digitally and our DGMS has a greater role that workplace surveillance system. That is very much criteria. And then what health surveillance, we have joint responsibility in the convergence meeting. If we share, it is such a gigantic task that it requires prevention, it requires detection, then it requires treatment, and then rehabilitation and compensation. So every step is a challenge. And in the process, there are different agencies are involved. If different agencies are not come together to converge on the proper issue to address this gigantic challenge, we shall be nowhere. Because we need to be developed country. To be developed country, we need minerals and mining. Without mining, we cannot develop. Because without mining, we cannot think of civilization. Every bit of life, every place of life, use of mines and minerals are being critical to our development and civilization. And while doing so, and mechanization is taking place in a bigger scale, replacing the large labor force. And with this big issue of mechanization, where accident rate may be reduced, but another gigantic challenge of occupational health is coming up in the form of silent killers. Occupational health, that is a very talking to increase in its dimension. So if we do not take care in time, it will be another natural disaster. So during this when the ministry was taking the NITI Aayog, the Supreme Court, the NGT, Human Rights Commission, all are being involved and activities they are taking to tackle this challenge. But still we don't have any light how this can be addressed, particularly unorganized sectors. Because in the loop, there is something we miss. I think the missing factor is the involvement of the local authority. That is our part. We are not able to assimilate all the forces who are definitely involved in the process with the involved state authority and state government. Without their help and without their active participation, may not be possible to address this gigantic challenge. Everywhere for training our doctors in the occupational health and detection process, in some recommendation we see to identify which clusters are having these medicine issues. If we identify which cluster of activities, what are the different activities are causing this national occupational health problem, and what are the different clusters, so that identify the activities and clusters, so we can extend our outreach to these areas to tackle the problem. That's why I have small suggestion that in this course of discussion, number of speakers are there, many recommendations will be there. Already one committee has been formed. After the committee will give some recommendation. If the committee thinks it necessary to incorporate two of the factors, apart from other already some we are already discussed, that one mobile unit with all medical facilities, if created with the infrastructure, we can reach to the cluster of mines and make a camp for 2 to 3 days and detect this problem and make aware. That will be very helpful. Another, because from other source also, we are not getting any feedback when people treat them as tuberculosis or silicosis or silicotuberculosis. So there is a differentiation. There is because doctors, fraternity are not properly trained or they are not aware of the different statutory provision. So in our national level, if we take one course in the medical course, small chapter about occupational health issues and its administrative or this regulatory provisions, it might be very helpful. So therefore, with this, I think already we have discussed many few problems. And another thing, in the long run, in the future, very near future, our Ajmer Region Director is conducting a very good program, that is pilot project with the help of this ESIC and DGMS and state authority, that we shall reach to the one cluster and we shall take the help of the state government authority. We shall conducting a health screening and awareness camp in the very near future. So if we are successful, we can scale it up to the other areas. So with this hope that this organization, this workshop will give a fruitful result and come with concrete conclusion, actionable points, and with this I hope best wishes and for the best happy new year coming 2025 to you all, and best of success for this workshop. Thank you all the organizer, participants, state governments, this UCI, this Chamber of Commerce Udaipur chapter, and our Sri Kumar Shah and my other colleagues. Thank you all again. Jai Hind, Jai Shri.
Thank you, Ujjwal Das. As sir said, this day-long sessions will deliberate the various recommendations to further recommendations to the regulatory framework for strengthening of occupational health and safety in mining sector. Now, before concluding, I request Shri R.T. Mandekar sir to present a memento to our guest of honor of the day, Shri Bhagwati Prasad Kalal sir, IAS, DMD, Rajasthan Government. to give a memento to Ujjwal Tara sir, Director General of Mine Safety. In the sequence, I request Mandekar sir to give a memento to Shri Arun Mishra sir, CEO SZL. I request Mandekar sir to give a memento Shri Mangilal Lunawat sir, President UCCI Udaipur. Thank you, Mandekar sir. Now, with the concluding of this session, we extend a warm thanks to Shri Mangilal Lunawat sir, President UCCI, for his always ready to go approach. Heartful thanks to Shri Arun Mishra sir, CEO SZL, for providing all the valuable supports. Apart from this, all the organizations of Rajasthan and Gujarat sector who have supported in this workshops to make it a grand show. We also request a warm thanks to all the officials of state DMG, to all the dignitaries and doctors who come here for a paper presentations, to the various officials of state governments, to ex-DGMS officials, and to all the volunteers who participated in the successful organization of this event. Once again, a warm thanks to all of you. There is a request to all the dignitaries to wear their ID cards. So, we request all the dignitaries to wear their ID cards to have a proper facilitation throughout the day. With this, we conclude the session. As I said, there is another session at the first floor for the small miners, and the next further day will be coordinated by Dr. Sarkar, followed by a high tea. Thank you everybody. We request all to have a tea in a short break of 10 minutes and gather on time so that we will be on time at the end of the day. Thank you.
should be put in, and biannual periodic medical examination should be done for early detection of both silicosis as well as tuberculosis. The healthcare providers, as we already know that healthcare providers generally do not ask for the history of occupational exposure to silica dust in TB patients. So we recommend that in all TB patients, healthcare workers should ask for a history for silica dust exposure. And of course, they require either intensive or prolonged treatment and care for silicosis patients. And as also mentioned by the previous speakers, that there is requirement of training for differentiating silicosis as well as tuberculosis on chest X-rays. These studies were covered by a few newspapers. The next project I am going to talk about is on latent tuberculosis infection and the outcomes of tuberculosis preventive treatment among the acute stone workers in Khambat. We found that the prevalence of latent tuberculosis among this particular occupation group was 58%, which is double than what has been reported for the general population in India. We also conducted in-depth interviews in this project, and it was said that we need to replace silicosis as the high-risk group for testing and treatment of latent tuberculosis with silica dust exposure. Given that 58% is just in against stone workers, and in which we found around 0.15 milligram per meter cube silica dust levels. So, of course, in other mines and all the other settings that we are talking about, the possibility of latent tuberculosis infection would be much higher, around 60-70%, and that is why. And of course, the notification of silicosis, we know that there are issues with it, and not many patients are getting reported. So, if we replace this as the high-risk group for latent tuberculosis treatment, it would be an important policy implication. Apart from this, they also said that when the prevalence of latent tuberculosis infection is almost nearly 60-70%, we need not go for testing. We can directly upfrontly go for TB-related treatment for this particular group. This study was also published in scientific reports and is freely accessible. Of course, these are covered by both Nature India as well as the Times of India. After testing them for latent TB infection, we ruled out active tuberculosis disease among these workers, and we gave TB preventive treatment. So there's a 6H, you must be knowing that we use isoniazid daily treatment for 6 months. This is a new regimen that is being employed by the National Clinical Registration Program, which is 3HP. So we give isoniazid 300 mg plus rifampicin 300 mg in a single tablet, and this is 3 tablets every week for 3 months, that is 12 doses. We completed these for almost around out of 194 eligible against stone workers. We successfully completed the 3HP regimen for 164. We received a completion rate of 87%. These are our project staff who have completed this particular courses. These are some upcoming papers that we have, that we are documenting this success of TB treatment, and also doing some implementation framework studies on this. We found adverse reactions were quite high with 3HP as compared to 6H. Again, we have a paper coming up on that. And silica dust levels, as I said, that we had 107 measurements, and after those and the average silica dust levels were 0.16 milligram per meter cube in the against stone workers. Ongoing, what we are currently doing in Siloi district of Rajasthan, just it was mentioned that there are stone carving workers over there in Siloi district. So we are actually implementing the TB silicosis collaborative, which we suggested has been published as an implementation research. We are also trying to look at the levels of silica dust which triggers tuberculosis among the stone carving workers, and we are going to measure the levels of isoniazid as well as rifampicin for silicotuberculosis patients versus TB without silicosis patients, because we believe that just our previous studies demonstrated that there is high level of treatment failure among those patients those workers who are exposed to silica dust. So we wish to see that whether silicosis plays any role in reducing their serum levels of isoniazid as well as rifampicin. And of course, we will also be documenting the latent TB infection prevalence in this particular group. In Udaipur, we are doing a study on the impact of TB on mortality due to silicosis, as well as a trial has been proposed on the impact of nutrition on TB reduction among patients with silicosis. So we are also proposing new projects where we will be looking at some different regimens other than the HSAB regimen. So there is the 4 months HPMZ regimen, that is isoniazid rifapentine, moxifloxacin and pyrazinamide among patients with silicosis, and we will look at the outcomes of these drugs. The THP which we have given for 169 against tuberculosis, we will following them up for over a period of 2 years for development of active tuberculosis disease. And we would be trying to look at the long-term outcomes of silicotuberculosis versus TB without silicosis patients. So we started from descriptive studies, and then we went to policy informing studies, and then currently we are in the delivery and trial studies that we are proposing. So these are our collaborators, basic care services, Udaipur, Dr. Manganese is heading that. IIT Delhi, we are proposing a Center for Advanced Research in IIT Delhi. So we will be working on certain engineering tools and controls to change the way that stroke workers are currently working in Silo district of Rajasthan, so that the generation itself, dust generation itself is reduced, because as we all know that the most important aspect of silicosis control is to prevent silica dust right at the source of generation itself. With Cure and Madhuri, we have started some of the work on differentiating silicosis as well as tuberculosis. We have received support from the Social Justice and Empowerment Department, Government of Rajasthan, and for advising the silicosis and silicotuberculosis research at ICMR and IOH, we have now an expert advisory group meeting. The first meeting was held on December 6, 2024. So they will be guiding us on how exactly these projects should go and whether they are getting implemented correctly or not. So what is the way forward? So of course, that source reduction of silica dust is very important, and we are working towards it. Any silicosis now should be included as a comorbidity of tuberculosis. People have highlighted, the program highlights HIV, diabetes as important comorbidities, but silicosis somewhere is forgotten as well as the National TB Leadership Program is concerned. Any patient with silicosis is a potentially active TB disease case, and it should be treated, tested as well as treated. Potentially require something else than what we are conventionally doing, which requires, of course, more further studies to document what would work for the silicotuberculosis patients. Those who are exposed to silica dust for more than equal to 5 years are potentially latent TB infection cases, and if in a setting, let's say in a mine setting or maybe in a factory setting, we find that we test a random group of, let's say, 100 out of 1,000, and we find that almost 70% or 60% of them are having latent TB infection. We did not test more silica dust exposed workers. We can just directly go for the upfront TB preventive treatment of 3HT regimen. Any active TB case should be investigated for the occupational risk for silica dust exposure. And of course, the implementation of diseases collaborative activities is so I thank ICMR and IOH, my gurus over here, Dr. Dignitary and Dr. Silicosis, and many other collaborators as well as GMS. Thank you for the presentation.
Thank you, Dr. Opani. Completing the now I will request for the chairman has the
now I have one question in the what are the results of this
yeah, so currently we are developing against purposes. So now we are just starting in January, supporting
and the other is that we have many data for the extremely concentration labor.
Yes. Yes. So it was the silica dust concentration was 0.16 gram per kg. I don't remember the total was silica was 0.16 gram per kg.
In terms of percentages,
it was like 8%.
Thank you from my side.
Thank you, Chairman. Sir, now request any questions from audience. Fast, we are running out of time. Anybody who wants to ask any question? Please give me my mic. Please introduce yourself, sir.
So, your Silicosis is the TV. Any relation to the pneumococcal is the process. Full organ pneumococcal is TV.
There are susceptibilities which have demonstrated cold dust, of course, first is silica dust, second is cold dust, and some relatively cotton dust have been demonstrated with tuberculosis.
Okay, anything, any improvement in the long life with the increase of immunity or nutrition in the tuberculosis?
We have a post-study for persistent. We are looking for those analysis. We have a post-study for persistent.
Thank you.
Any more questions? Please come on. Please introduce yourself. One question, please.
I am from Union Corporation of India Limited, Jharkhand. My name is Dr. Silicosis Sharma. I want to ask you for diagnosing silicosis, whether HRCC is better we can confirm it.
So, experts say that in 80% of cases they are able to differentiate because of silicosis is not just a disease. Only 80% of cases we need to go for HRCC. But these are, those species who are being at these species are really diseases. They are easy able to differentiate just as regular diseases. They need to go for HRCC only for a handful of cases.
HRCC is not available everywhere and it is also not cost effective. So, we can confirm it or not.
Actually, what he says is correct. 75% cases, we are in a position to differentiate between. Only the cases of the very fine and go for HRCC. And we will see the socioeconomic condition of the situation. In our country, for a only diagnostic, you do not come for HRCC randomly for any type of condition. 75% can be 75% can differentiate. But some cases we will go for.
And what about Manganese?
I'm not heard of
Next question is one more question. Please introduce yourself.
Sir, I'm Dr. Surya, Quality.
Now we go for the next session, which will be deliberated by Dr. Devendra Kolikar, Director Medical of DGMS. A brief introduction of Dr. Devendra Kolikar. He is a 15-year experience in the field of occupational health, conducted national surgery in resources, national study in asbestosis, national study in health hazard of textile workers. Work posted as a Directorate Medical Research Officer is probably the selected aspect of which with reference to factor 40. So there are the concurrencies.
Carcinogenic effects or in my opinion. So one has to ensure that those workers working in the hazardous processes, their separate medical records has to be maintained, and it has to be available for inspection for the inspecting authority, as well as this record has to be accessible to the workers also. So this is about section 41C. Then section 45, first aid appliances. This, I think this particular provision is very explicit. There is no ambiguity in the factories act and any state factory rule. They have given the list of first aid appliances. One first aid appliance or first aid box should be there behind every 150 employees, and the content has also been given. But if you see the content few of the items, they are not available in the market, and there is no relevant of these items also. So DGFAS has constituted a committee to revise the content of the first aid boxes, and it will be revised soon and it will be included in the by amendment or probably in the wash code. So it is about first aid appliances. Another important is empanelment of trained first aiders. So again, there is no uniformity all over the area, and this is one of the major challenge for imparting trained first aider to create or to train first aiders in the factories, because a few states they are having their own system of empanelment. Like DGMS is also having their system of empanelment of first aid training institute. Just last few months back, I have visited in NLC India, where they have empaneled and the beautiful first aid training center is available. But in most of the states, more than 50% state in India, they don't have any system of empanelment of trained first aider, where we cannot ensure the quality of first aid training. Then power to require medical examination under Chapter 7 of 75, Section 75. So this medical examination is mainly related with the fitness certification. I have seen many accidents in the ports, as DGFAS is enforcement authority in the port. Many accidents are I have observed because of examination of that particular employee is not as per job specific. So the medical examination, I have observed crane operator met with an accident, and they have conducted all the tests in the port hospital, which is all port hospital is equipped with all specialties, but they have not conducted the litmus vision test. So that is one of the defective stereotypic depth of the vision. That was the reason of that accident. So fitness certification one has to ensure by factory medical officer and certifying surgeons at the workplace. That is one of the challenge to control the accidents at workplaces. Then dangerous operations, like we have discussed in the section 41C, like hazardous processes, there are listed dangerous operations where employee is permitted with specific kind of medical examinations, and that kind of medical examinations is, I have seen, not conducted in a proper manner. So we have to ensure that like working at height, one has to know about the history of the patient, that whether that person is suffering from any kind of neurological diseases or convulsions or any other psychiatric history, or whether he is on the medication like anticonvulsant medication. So such kind of medical history along with the proper medical examination will be helpful before employing the workers in the dangerous operations. Then in context of hazardous processes and dangerous operation, one more important thing is that those employees, those who are suffering from occupational diseases, they need to be diagnosed, because it is after all occupational diseases are having medical legal implications. So in diagnosing and proving that this disease has been developed out of his or her occupation, so one need to have evidences in the form of medical records, history taken, diagnostic reports, but in addition to that, they need to have records of works on environment monitoring. So I have seen many factory medical officers and medical officers working in their respective workplaces, whether it may be dock, port, or construction site or plantation site, they are least interested in works on environment monitoring. So this kind of qualitative and quantitative analysis of industrial contaminant, that is very important in establishing cause-effect relationship to diagnose occupational diseases. For example, employee suffering from silicosis, we are having chest X-ray. Even chest X-ray findings may be there, axial calcification, fibrotic changes, everything. But we need to know about the particulate matter of ozone environment monitoring, like qualitative and quantitative analysis of dust. So how much dust that person has been exposed, so we need to monitor ozone environment monitoring, breathing zone monitoring we need to know, and the quality also, the percentage of silica. So likewise, the ozone environment monitoring is available in every aspect. So we can measure vibration, we can do ventilation study, we can do illumination study, so we can do noise monitoring, noise sampling. So likewise, a factory medical officer should insist management to obtain a ozone environment monitoring. Regarding the medical provisions relating to ozone environment monitoring, Factories Act is telling about ozone monitoring has to be conducted, but periodicity and frequency has not been decided by the Factories Act. So again, DGMS has constituted a committee for deciding the periodicity and frequency of ozone environment monitoring, and we will soon come up with the these findings, and that will be mandatory for all employees to implement the provision for ozone environment monitoring. Another important section is 91A of the Factories Act, where the authorities with DGMS, DGHS and any other central government to conduct surveys, studies, accident investigation and any other activity and any other matter related with the occupational health, under which we have conducted different surveys like National Study on Silicosis, Escort, and National Study on Health Hazards of the Textile Workers. So I think these are the important areas where we can ensure the quality medical examination. Another important challenge is like all state factory rules, they have not mentioned about the prices of medical examinations. I have seen Maharashtra state factory that they have given a price for medical examination. So in one end, ESIC is giving medical benefit to the workers where they have given the price, and their charges for this test are at par with the CGHS rates. But when we are implementing the preventive aspects, we are conducting the test as per the Factories Act, Mines Act, BOCW Act or Toxicity Act, the prices are not fixed. That is one of the reasons the quality of medical examination has been compromised, and it is one of the major challenges what I have seen during my visits to the factories. Another important challenge what I have seen is like accreditation process. We don't have accreditation process before entering the authorized certifying surgeon. The factories are conducting medical examination where the diagnostic centers are not accredited. But nowadays states are coming up with the policies to frame the empanelment for accredited diagnostic centers only. Like Maharashtra state, 6 months back they have framed a policy that the medical examination by authorized certifying surgeon needs to be conducted from NABL accredited diagnostic laboratory only. So nowadays they are improving, and the medical record, maintenance of medical record. So I can quote one good example of Chhattisgarh state where they are maintaining the medical records with respect to all the factories in digital forms, and the factory medical officers are sending regularly these medical records in digital forms to the certifying surgeons, and certifying surgeons are having that facility to evaluate that medical examination in soft copy. And in that soft copy, they find something adverse, they can visit their workplace and they can inquire the matter, or they can direct the employer to conduct the medical examination as required by them. So these are the I think medical provisions are there as per the Factories Act, and these are the challenges that we are facing right now. But main aim is prevention, and different agencies are there. For mines, DGMS is there. For factories, state government, DGMS is there. For dog safety, DGMS is there. So at the end, in the nutshell, my opinion is that we need to have unified policy for prevention of occupational diseases at the workplaces by enacting a unified code in the form of OSH code or like that, so that we can implement the medical provisions in effective manner. Thank you.
Thank you so much, for finishing on time. With the permission of the chair, I have just one question.
Yes, sir.
You have talked about the certificate serving. What about the medical inspectors appointed by the state? Are they appointing and the posts are all lying vacant?
Sorry?
Medical inspectors.
Medical
Under the
they are appointed by the state government.
appointed, but are they appointing other vacancies are filled up? What is the status?
That is one of the challenges that I have discussed in chapter 10.
Okay.
Most of the states like Chhattisgarh, Jharkhand, Madhya Pradesh, Uttar Pradesh, Jharkhand, and few of these southern states, they don't have medical inspector of factories or certifying surgeon. So there is no enforcement.
No enforcement at all. That's the problem.
So that is the main reason.
So any at the DG first, because DG first is a nodal officer under Directorate Ministry of Labor.
Yes, sir. Yes, sir.
Any action is recommended from the DG first?
Yes, sir. Yes, sir. We have proposed in the CIF conference, Chief Inspector of Factories. All the chief inspectors of respective states, they have came together. So we have conducted last year in Odisha. So where we have kept the agenda that we need to appoint all the certifying surgeon, and the model adopted by the state of Maharashtra appointing authorized certifying surgeon in the respective district of that respective state.
No, in addition to certificate, they appoint inspectors also.
Yes, in addition to certifying surgeon, because thousands of industries are there, it's practically impossible.
Because as far as my knowledge is concerned, certifying surgeon does not have the power to prosecute. It is only inspector.
Yes.
In Goa it is there, but in Maharashtra I don't know what is the status.
Yes, sir. In Karnataka also one of the
Yes.
Karnataka they have.
Dr. Suresh was there.
Yes. He has done that thing, and he has prosecuted many factories, and that power was with him. So basically, certifying surgeon, medical inspector of factories, though the inspector of factories it is written in their name, they don't have power of prosecution. Prosecution has to be done by the inspector only, but the necessary inputs has to be given by the certifying surgeon.
Over to the chairman, sir.
I have no specific questions for Dr. Prabhu. Thank you. Now it's open to the house. Any questions from the audience?
Please give him a mic, please.
Good morning, sir. First of all, I would like to thank Dr. Director sir for mentioning, first of all, I am Dr. Karthik from NLC Limited, the Government of India PhD. I would like to first thank sir for recognizing our NLC Limited First Aid Training Center. So thank you, sir, for mentioning our center. On this point, I would like to thank Dr. Kaushik sir also, because he was the one who guided us to apply for the training center.
Please ask your question.
Yes, sir. Regarding the first aid training only, sir. Like in Mines Act, we have special things like for people working in mines, like mine managers, mining board, they should have a valid first aid certificate. So we don't people, sir, but whether that most people should hold first aid certificate like that. Because
yes, certification will be awarded after successful completion of the training, and that certification is valid for 2 years, and certificate duration is of 3 days, and after 2 years, that trained first aider has to undergo refresher course of one day every 2 years.
what means like in DGMS issued circular, there is a gazette qualification, the first aid certificate course should be for 11 days duration. So, but it is somewhat very less, 2 to 3 days is very much less to convey first aid procedures to people. So that is also thank you.
Okay, thank you. Any more questions, please? Yeah.
Namaste, myself Dr. Sonia from Adani Cement, Lakheri, ACC Cement. So my first question is that I have 2 questions.
No, only one question, please. We are running short of time.
Sir, I need to know the names of certified surgeons for Rajasthan. Who are the certified surgeons for Rajasthan?
Rajasthan, last year I have visited. I will share you the contact if required. One doctor is there who is on rehabilitation from the Dignitary department. Only one doctor is working for Rajasthan state. I will share the contact.
Okay, so because I haven't seen any man.
So he is there and he is visiting factories also, and he is very meticulous in his work.
Is certificate surgeon or assistant surgeon?
So you need the name and number.
Okay, you will share with you. Any more question? Only one question. No, please, ma'am. Any that it is better that you search at each side. That kind of at this side. Okay. Yeah, please.
This is Dr. Heath, the son of psoriasis and delay. It was excellent, sir. So thank you so much. The presentation was very informative. Just one question from my side. So far as compensation or prior to compensation, isolation. This two terminologies is coming across for any doubtful or endorsed case of occupational health disease, any occupational disease. What should be the role of certified surgeon if he is there in the state? The role of certified surgeon in case of isolation and compensation, two different things are there. Isolation means it is a simple thing. A worker working in some hazardous area or dangerous occupations or any area where he is suffering from disease. So positive relationship we have established and disease has been diagnosed or that person is met with an accident, he has to be isolated. So that person has to be separated from the workplace. It has to be posted at the workplace where such kind of occupational hazard is not there. That is one of the we can see near reading measure. So you are saying it is isolation. But compensation is completely different. So certified surgeon has to refer that patient to the compensation commissioner. So compensation commissioner is having dedicated power to compensate. Compensation commissioner will award compensation on the basis of report obtained from the competent authority, that is in any state is ESIC. All ESIC. So doctors of ESIC will calculate compensation on the basis of this disability and IPS. So that any person suffering from any occupation disease or disability, the disability adjusted IPS will be calculated and compensation will be awarded on the basis of, like for example, a person suffering from silicosis, having acid fibrosis at the age of 40, for example, and that person is working for 10 years in a factory. So, and his life expectancy is 67 years. So that committee is of opinion that his life expectancy is reduced by 5 years. So 5 years will be calculated, and that person is suffering from silicosis, doctor in acid fibrosis state.
we elaborated with the compensation commissioner of the state government, and they recovered from the unit where my person was working on MRI. Thank you, Dr. Vagar. Now, for the wonderful presentation and wonderful question answer session, I will request the chairman of the session, Dr. D.G. to come to the center stage and hand over his revenue to Dr. Vagar to share in his assurance. Our next speaker is none other than Dr. Dignitary. He is the expert of Silicosis and consultant, Governor of Rajasthan. A brief, if I want to read the introduction and go in volumes, I will just read the salient points of the introduction. He is an MBBS in 1974 from Oil Institute of Chemical and Chemistry and postgraduate in Occupational Hygiene from the University of Newcastle, UK. He retired as a Director of National Institute of Analysis with 40 years of experience of dealing with occupational health and hygiene, issues in asbestos products, industry, mining, building and construction industries. Earlier, he worked as Deputy Director for Mine Safety and Officer in charge, Occupational Health Division under Government of India Administrative level. Presently working as consultant, expert in silicosis for implementation of silicosis prevention and research. And he is responsible for formulation and implementation of Rajasthan policy on pneumocommunicants, including silicosis of detection, prevention, control and implementation 2019 under the Government of Rajasthan. He was the past president of Association of Occupational in 2000 and resource person for Ireland and the specific interest in Ireland Association of Justice. His topic will be Rajasthan silicosis policy, implementation, achievement, challenges and reform. Please welcome him to the round of applause.
Thank you, Dr. Kaushika, and gratitude to Director of Mine Safety for inviting me to this particular seminar. Before I start, I just pass one comment. What I'm hearing from the audience and the questions, please go back and read your act and books. What are actually able to do. So most of the questions that we raise here are because the ignorance of the people regarding the restricted provisions. So please go back and look at your legislative requirements. So with this initial comments, I will share my experience regarding Rajasthan Silicosis policy implementation, challenges, achievements, and way forward. I have had the privilege of working in the silicosis field for almost 45 years now. And I would say every monument is built on the grave of mine workers. And I said it repeatedly in almost 20 countries. Whatever be the monument, whether the federal temple or the Amir Fort or only palace or city palace, it is built on the grave of the mine workers. And this is the family. I go back to the Inaugural session, Mr. Kalam working in this particular mine, which was basically totally manual, I visited this mines and in fact I talked to the DG that time, Dr. Silicosis, the director, and tried to convince him that these are cases which are suffering internally. And it was very difficult to comprehend for myself as well as this colleague, how can Silicosis succumb to these kind of mines, which were very, open environment, and absolutely manual working, and it became very difficult to convince myself as well as user. But this is the typical workshop which Kalasa was talking about. This is also considerable. What we find is that these people are working in very uncontrolled conditions, work conditions in soil which is its own context. And this is a typical of, you might have seen this powder making for the quartz grinding practice. And it's another big area which is the Silicosis last time. Now, this publication report of Udaipur that led to chain reactions in last time. I would say the last one was the person with the age group of the silicosis, which is because of the stone carving and because of the mining. What we are seeing here is the peak of distribution cases occurs in 31 to 30, 40 in case of stone carving, while in case of mining, it is basically 40, 40, 45 years, 50 years. So the distinction as far as the mining work is concerned, as well as in case of the stone carving work is concerned. Same trend we see in case of the deaths due to silicosis also. And this is based on the data of around 4,200 cases which were we have analyzed. You find that the same difference in the mining. The deaths occurs later in comparison to stone carving industry. That means people in stone carving industry, they are developing silicosis much earlier, almost by the gap of 10 years, as well as dying much earlier also in comparison to mining. This is a typical case of silicosis in stone carving. There is sometimes you find they begin by the excellent picture you can make out from which part of the country, which part of the Rajasthan the person is working. This is typically what happens in case of silicosis in stone carving. This is, you might be find this probably if you look at the layout, the focuses are a bit larger than comparison to stone carving, and then of course the silicosis here. This is important finding. And the distinct difference which we are seeing is because the exposure levels are different. In case of mining, the exposure level is much less compared to stone carving, and of course when you look at the stone grinding, what grinding limit, things are far, far worse than what you see. This is the data of when we analyze the total number of workers reserved 181,000 and all. What we find is that because then the mining is by 3.14%, the use level of the stone carving is much higher. The difference is seen in the deaths also and certified cases. That means the number of deaths and number of cases being certified in building and construction workers is much higher compared to the mining. As far as the area as Mr. Karan was showing, another district is the Dosa, where most of the carving work goes on. And what we find is that these two districts are contributing almost to each other 2% of the work of silicosis cases, and almost 81% of the deaths due to silicosis in each. Because of the number of the construction worker means both. You see, stone carving, by definition, we are into construction, both the stone carving as well as the other construction work. So what these two districts have is a very high percentage of stone carving units. The Dosa and Slowly, and what we find is the number of death cases which are contributed by these two districts as well as the silicosis cases is much higher compared to the other construction works. Now this, we realize after 4 or 5 years experience that this particular problem with silicosis is not confined to mining industry or to the stone carving industry. The problem was far wider. So it was decided we must draft the policy for the whole of the Rajasthan. And with that, we drafted the Manganese policy 2019, and this was officially inaugurated in 3rd October 2019 by then Chief Minister Mr. And this is the basic mission of this particular policy. The mission of the policy, the Manganese policy, in Rajasthan, the prevention and control of Manganese as an occupational disease with ultimate elimination and provide relief to the rehabilitation person. Let me clarify here. The policy is basically for relief. It has got nothing to do with compensation, it has got nothing to do with factory act, it has nothing to do and they said that some guy was talking there at home. Then we have created working conditions, unregulated working hours for migrant workers, increasing your powerfuls and leading the rest, migrant enforcement, legislative adequacy. The majority of these measures are not covered by the registration. Maybe awareness for the silicosis. How does the system operate? Because when we are examining on 2 lakh persons, there has to be a system. What we have done is, you can go to any village, even if you go to any part and there's an email which is available, where you can register any person, even if you wish to be examined, you can register yourself. And then once you are registered based on the especially issued by the Ministry of the Assam, that information goes to the doctors and doctor. There are 129 medical centers which are mapped on the portal. And this doctor will give you an appointment for the examination, which is within 20 minutes of registration. And then he examines, and if he feels that the person may be suffering from silicosis, then he goes for medical examination and for a radiographic examination. That is, he has extended this access uploaded to the portal, digital images uploaded to the portal, that goes to the radiologist. If you go to the radiologist, and simultaneously that also goes to the AI tool. And AI tool analyzes the data, and that uploads to the radiologist also. So the radiologist has a look at the X-ray here, opinion of the AI tool, as well as based on that, he will make a decision whether the person has silicosis or not. And that information goes back to the medical officer A, and what based on that person is the medical officer generates a certificate. And this certificate, once it is generated, it automatically goes to payment. And what happens is that now because of the irregularities we have observed, we have put the certificate, essentially the concept was as soon as certificate is generated, even the funds are available, that goes into the bank account of the person. So ideally speaking, we can finish the whole process in a day for the certification and payment. And this particular portal is linked with all other portals. So the person he has to go and apply only once. Once he is applied, all the process is online. It only entitled to various schemes of the government. Now, this I skip because training unit for the stone carving units, and this is my final side. There are no solutions. Whatever we might say, silicosis will remain a challenge for years to come, not only in Rajasthan but all over India. A comprehensive approach to detection, prevention, control is essential in any medical prevention case of silicosis situation. Thank you very much. I'm sorry for wasting my time.
No, your time was required. I have, before I hand over to the chairperson, one of the things from, first of all, you have put 139 camps in Rajasthan. These camps were done under whose model agency? Is it the...
This is the 39 camps which we organized by the Labor Department, not by the
Labor Department.
So we went to the field, organized wherever there was a requirement. Medical and we had almost 10 camps.
Right, but who are the supplying the samples? Because the training samples are very
This is not open. Anybody can walk in there. Who think that he needs something was it was a given working there.
So you know they themselves are the problem. There is no.
Don't provide the data saying this does not reflect the relationship. Please verify that. These are the people who came to the camp saying that they had a problem.
That is all.
So the tip of the price in a sense. So I think
that's a model together. Not that you require 4 people.
No, it was not a survey. It was
in our camps. These are some of it. Another thing was that all the district hospitals. You have so many field doctors in the
we have used the existing setup which is available. This creating a new setup is a problem. What we have done is use the existing setup of the state government under which the doctor's responsibility is only examining the patient. And this is related to the requirement.
It's a screening part.
It's a screening part. Okay. Then the X-ray is uploaded on the portal. It goes to a radiologist.
Your uploading is basically a manual X-ray digitized.
Manual is only for screening.
Only for screening. Okay.
The rest of the portions are digitized.
No, but if it is a digitized X-ray, you have to follow the digitized protocol of ILO.
That is true, but you see, let me clarify a few things. We are not going by the ILO classification. Okay. The reason is very simple. This is a relief scheme. This is not a disability violation scheme. Certified in case of silicosis. And the other things which I would say, this is a relief-oriented scheme. So the benefit of doubt goes to the patient. Even if he has if I cannot rule out, and if I have slightest inclination the person might be having silicosis, we'll give the relief. That is the approach. That is why there is a. Thank you, sir.
Hello. Okay, thank you, Dr. Shivalia, for a nice presentation. And let me tell you once to you that Dr. Shivalia, incidentally, is one of my PhD supervisors. I worked under his supervision when I was working in National Institute of Miners Health. So I should not give a chance of questioning my own supervisor. Given the chance, definitely I will try to improve my knowledge only. Sir, just two questions only. Only thing is, yesterday also we have been discussing in the guest house that how to improve the reporting. That is to reduce under-reporting and the number of cases. How we can get the chance of screening those things. Yeah, sir.
I think I was brooding over the same when we have a discussion what should be. I think now the changing scenario, the DGMS must have its own portal where every person who is be registered should register and that data should be available to DGMS. So you have and there you cannot have the screening, put an artificial intelligence tool now. They are available. You may not have 100% accuracy. Say we have accuracy of 90%, we are improved, maybe we reach around 95% or so. Because we are starting validation all over again now with the tool. So and where there is a doubt, wherever the artificial tool says that, look, there is a case of, possibly case of silicosis, it goes to the trained person of radiologist. So maybe that kind of system you have, then you will have a uniform standard. Otherwise, it's going to
What about your system and DGMS system?
Problem is your system and the DGMS system, as you know very well. Your system, people are voluntarily concerned to get themselves checked.
No.
But in the case of DGMS, they tell people because patient is suffering also. वो भी बोलेगा सर मेरे को कुछ नहीं हुआ, गुरुकुल का बोल तो सिलिकोसिस हो गया.
That is why I said
that is
what every person who is registered under your be registered. That should be the criteria.
That was
so you have a database available.
Yeah, because it's not voluntarily possible. So it has to be there in the system itself. There has to be. And so the next question is small one. You have used 38,000 cases for training the AI model.
Yeah,
exactly. Yeah. So even then we are achieving something around 87 to 88% reliability in these things. So what is your suggestion as you are in applied research to improve this model efficiency so that we cross at least 95?
See, one of the major reasons why the AI is committing mistakes is because of poor quality radiographs. Because these are field X-rays which are taken. We have used 38,000 field X-rays. So large number of these X-rays are not good quality. So if you have good quality X-ray, then the model will be good. So now we are revalidating the model and maybe we will reach 90-95%. That's what I'm doing.
Thank you, sir. Open house.
Any questions from the house? No, Ramesh asking somebody else.
Let's ask Ramesh Babu. We'll give him the.
Okay, one question please. Only one.
This what you are proposing is AI tool. Is it available to also?
Which is that?
That AI tool to diagnose the X-rays. AI tool, artificial intelligence tool, which you are installed or which you are proposed, is it available to one also?
No. This is developed for this particular portal only, and this is still an experimental stage. And we have used the Manganese cuts because they were normally charged around 5 crore rupees because they are noticed to the national government.
Let Rajasthan government be largely.
No, Ramesh, what you say is very clear. It is only a pilot project and still experimental stage and cannot be used for legal purpose. It is only for relief purpose. There is a difference between legal purpose and relief purpose. They are giving relief.
You see, what I have someone said in Rajasthan, we happen to have the right person at the right time at the right place. So, starting from this is off the record, starting from the Human Rights Commission to the NGOs to the bureaucracy, even politicians. They took up it as an issue. So these things have been rather smooth in Rajasthan, and many people ask me why Rajasthan has succeeded while the other states which have created policy like West Bengal, Jharkhand. I think the way we have implemented it, the online system, anybody can just walk in and get this, and then it must show that they are getting the benefits. If you take 3 years to give the compensation or relief, it makes no sense. And that is the basic drawback of most of the research projects. See, the patient, you give the results to the patient after 2 years. It doesn't make a sense. So once the patient if he is certified, he is going to get money within 15 days or 20 days or within 1 year also, then he has that kind of incentive.
Thank you. Great relief was government of Rajasthan was proactive to accept the reference.
Yes,
the Labour Department has supported. Otherwise, it would have been very difficult. Any other question? One more question, please. Yes, please give me a mic.
Good morning, sir. Chief Medical Examiner. So my question is that 3-day, 4-day program iron classification training is usually conducted with institutes. How is it capable as to diagnose case of silicosis, or if it is not possible, to how to replace silicosis mining?
This question I don't think exactly related to him. We are talking about the first story. You are opening a Pandora's box.
I was just discussing the island concept during the tea time. DG, I was just proposing we must learn. So last week when I was in NIMI, so when this one was in 2011.
That is a different issue to pick out altogether. What we have achieved after doing AFH, what we have achieved after doing DIH, what we have achieved after doing 3-day course in ISO classification, how much you have completed, that is a Pandora's box. So I don't think this is the forum to discuss all this.
Sir, how frequently we can refreshment courses about this ISO classification?
After doing MD, I don't know how much person competent. After doing a post-graduation, I don't know how much competent in that subject. That's a different issue. That is a totally subjective thing. So we can discuss and debate many things, but I don't think this is a forum to discuss about it. Yeah.
Thank you.
Sir, you have shown the 3.7% of mining workers for silicosis and diagnosis. Is mining include only mines or crushing units or other activities?
No, this is based on the geographical location. We have not.
What is the meaning of
mines? We have identified mining districts. We have identified stone carving districts. We have started. So that it is not by the registration of mine. No.
They have done by units. In fact, crushing unit with a carving with a mines with a and as insect more on the carving and quelling.
That is not showing the exact picture of silicosis in mines particular. So some distinguishing between mining and crushing units.
Normally, you want to distinguish how do you distinguish? Sometimes you say mining being disease developing after 10 to 15 years only. So the features are little different. That means you are going to get plastics which are much larger in comparison to what you have in we are when the person is coming to diagnosis stage, right? While in case of stone carving units, the particles are much finer. Same thing in quartz grinding, you find the almost acute silicosis cases also. So distinctly you can make out.
By selecting the locational person in crushing unit or in mines, we can focus on that point. If crushing point are more prone to silicosis, then we can focus on that.
Mixed population.
Mixed population.
That's why you still have out of these 42,000 cases, probably 35,000 are from the Rhine mine, mainly from Jodhpur. Then your Karoli, Nagaur. These are three major districts. So let's not say the mining is all good. I'm saying I've been working for the mining sector for the last 30 years now.
Okay, I think.
Thank you.
Okay, last one.
सर जैसे कटेरा साहब ने कहा उसी के एक्सटेंशन में जा रहा हूँ जो ये डेटा है ना सर आपने माइनिंग और BOCW सर ये वास्तव में मिसलीडिंग है क्योंकि क्या था जब ये पहली बार जब शुरू हुआ था ना सिलिकोसिस तो पहले इसको माइनिंग से जोड़ के देखा गया था और जो भी आदमी रजिस्टर करता था उसको पता था कि मुझे यहाँ से मदद मिलेगी तो जो वर्कर था वो यही बोलता था मैंने फला माइंस में काम किया है तो एक्चुअली क्या है आपने देखा भी होगा सर जो एक्सपोजर है सर डस्ट को वो क्रशिंग यूनिट में या कार्विंग यूनिट में बहुत ज्यादा है बहुत ज्यादा माइनिंग में क्या सर एक तो लिमिटेड पीरियड के लिए या तो ड्रिलिंग कर रहे हैं या कुछ है बहुत कम एक्सपोजर है तो सर इतना फर्क आएगा सर सही कह रहे हैं कटेवा साहब का कहना है कि माइंस में तो हो सकता है लेस देन 20% वर्कर्स हों और ये कार्विंग यूनिट क्रशिंग यूनिट में 80% हो अभी सर पर आप ये सर जैसे जैसे धीरे धीरे
I wish sir I could agree with you. जब पुलिस ऑफिस में डीजी थे उनको कन्विंस करने उनको कन्विंस करना मुश्किल होता है सिर्फ करौली में आई बीन माइनिंग इंस्पेक्टर विद डॉक्टर कौशिक 18 इयर्स DGMS में
जी सर
और मैंने सारा कनेक्ट इंडिया का मेजर माइंस करते से भी देखा हुआ इधर कोल नॉन कोल ओपन का अंडर ना ठीक है ना तो
sector we cannot say that there is no silicosis occurring. But majority of these cases are not even covered by Mines Act. After जो जैन साहब पहले थे, जैन साहब registered these mines, and you see it was very difficult to combine.
Mines Act but not registered.
Not registered.
सर ये इससे भी समझा जा सकता है कि सर सैंडस्टोन के बड़े एरिया जो जोधपुर है, करौली है, बूंदी बिजोलिया है, तो बूंदी बिजोलिया का वो कार्विंग के लिए फिट नहीं है सर सैंडस्टोन, आप देखेंगे बहुत कम है, तो वहाँ से आपको केसेस भी बहुत कम रिपोर्टेड मिलेंगे सर। आप अभी जब भी आप देख रहे होंगे आपको ज़्यादा पता है, पर बूंदी बिजोलिया के जो भीलवाड़ा के हैं सर और बूंदी के हैं, आपको बहुत कम केसेस मिलेंगे सर। उसका कारण यही है कि सैंडस्टोन माइनिंग में इतना नहीं है जितना कि कार्विंग क्रशिंग नहीं है। और सिकंदरा सर दौसा जो आपने बताया वहाँ सैंडस्टोन माइनिंग नहीं है, लेकिन वहाँ कार्विंग इतना ज्यादा काम है सर। और जैसे सिरोही में बताया सर, सिरोही में भी सैंडस्टोन।
देखिए मैं इतना कहूँगा, whatever we are seeing is just tip of the iceberg.
नहीं बहुत अच्छा काम किया है सब अच्छा, लेकिन जो डेटा है ना सर वो एक्चुअल रिप्रेजेंट नहीं कर रही है।
डाटा हम लोग उतना exorbitant डाटा है ही नहीं है। What Rajasthan these people are doing?
Will you believe कि DGMS में चार केसेस सिलिकोसिस सारे में सही है?
सर वो इसी कारण है कि जो माइनिंग में है ना सर, माइनिंग में जो अनऑर्गेनाइज्ड सेक्टर है सर माइंस के, उसमें वर्कर साल भर काम करता है, 2 साल करता है, फिर दूसरी माइंस पे चला जाता है, कोई दूसरे काम में चला जाता है, तो डीजीएमएस को रिपोर्ट ही नहीं होता है ना सर।
we can conclude it here.
Thank you so much.
Thanks very much, and I especially thank Dr. Tasa and all the DGMS officers, ex and the present. And it was a pleasure meeting all of you after a long time. So I'm really thankful to Kaushik and all the DGMS officers and the DGMS especially for inviting me to share my experiences here. Thank you. Thank you very much.
Thank you, sir. Please come to the secretary once. We will just, in recognition of his expertise, we would like to just honor him with a piece of memento by the chairperson, Dr. D.G.M.S. Thank you, Shishadya sir. Now the last session of this, last speaker of this session, Dr. Pradeep Taswan from ESIC Medical College, Alvar. Dr. Pradeep, are you here? Dr. Pradeep Taswan? Okay, where is he? Dr. Pradeep Taswan from ESIC Medical College, Alvar. नहीं डीजी के साथ नहीं है। So before he comes, I will just review his brief introduction. Dr. Pradeep Taswan, he is MBBS and MD in community medicine and Master of Hospital Administration. He is Associate Professor and in charge HOD, Department of Community Medicine, and Coordinator AFI, the Associate Pharmaceutical Industry ESIC MC Alwar, Rajasthan. His topic is Prevention of Silicosis, Regulatory Measures, Role of ESIC. Dr. Pradeep Taswan, please.
today we are discussing about silicosis. Many of my previous delegates and dignitary, they have discussed regarding silicosis. You must be aware of all these things. But the main problem is main problem with the awareness of the people and awareness of doctor and patients. You all very well aware of the silicosis is mainly preventable disease. Means if once he is diagnosed, then there is no other treatment or something. Means he has to die slowly. So you have to die. We are saying one thing: the prevention is better than cure. That is most true for silicosis. Means if you do these things earlier, then you can prevent the disease. So those doctors who are working in industries where the silica exposure is more, then your role is very, very essential. So you have to give them advice and you have to prevent the disease. So we all are aware that pre-placement examination is there. In pre-placement examination, what we have to do? Like in Factories Act also it's mentioned that you have to do pre-placement examination. So you are aware of the status, whether he is having some kind of disease or initiation of disease or no disease. So later on stage, when the compensation is required, you can say something. He developed the silicosis because of this work or because of this occupation. So pre-placement examination is very essential. In that you can do physical examination, image testing like X-ray or chest CT. After that, PFT, pulmonary function test, sputum test, bronchoscopy or lung biopsy. This lung biopsy is very minimal role, and but in later stage it's very confirmatory. So inquiring previous exposure of silica, medical examination via sciagram or spirometry, these are most crucial things. And ruling out of tuberculosis is essential because we have seen the mortality is mainly because of silicotuberculosis, and prevalence of disease is also there. So you have to rule out the tuberculosis initially, and the diagnostic feature and X-ray imaging all are similar to that. So you have to rule out. And later on you have to do periodical examination. Once he is diagnosed, then you have to do repetitive examination like yearly or 3 yearly or like that. And that frequency should be increased. After that, various regulation, you all are aware of Workman Compensation Act 1923 and ESI Act 1948. Other regulation like Mines Act 1952, Factories Act, and Rajasthan Building and Construction Workers Rules 2009. So Dr. Sisodia sir and they are all working in that silicosis field, and they are imminent to this. So they are role model for the silicosis, and they are key for the policy making system. After that, various legal verdicts like Supreme Court and High Court ruling. We all are aware of Article 39 and 42 of Constitution, which are defining the rights and means what are the rights of workers, what benefit they can avail, what kind of leave they avail. And after that, historic judgment on occupational accident and disease on 27th January 1995, and Gujarat High Court case of 3449 Babubai versus ESIC. In that section 82 deals with the disability compensation. So he won that case against the ESIC. After that, NHSRC, like the Human Rights Commission, they also means looking very, because that silicosis, it's a very taboo-like thing. It's both for factories, both for workers. Because if he is diagnosed, he has to leave the job, and that factory person also has to pay some compensation. So Human Rights Commission and these people they are more vigilant in that area. After that, Rajasthan policy on pneumoconiosis. Sisodia must have discussed all this. In 2019, that Dr. Mihir Rupani sir also discussed in Rajasthan the prevalence of silicosis is slightly higher as compared to other part of India, and the prevalence of tuberculosis is 7%. 7%. Means those who are having silicosis, they are also having tuberculosis. So silicotuberculosis. So silicosis affected worker welfare scheme, financial assistance provided to workers and their family, silicosis पीड़ित अधिकारों हेतु सहायता योजना. In that 3 lakh provided to silicosis certified patient and another 2 lakh to their family in event of the death. After that, what are various workplace measures? In that we can keep breathing zone sampling we can do. In that that air monitoring we have to do. How we have to do? Keep from 0.3 meter from the nose or mouth. We have to place that and we have to monitor the air. After that, permissible exposure level of silica, which is 50 microgram in meter cube by 3 hour time weighted average. Other line of protection like water cleaning system, air quality monitoring, respiratory and other personal protective measures. These are weight working areas, and these are like cement and all this, and some are dry working areas like stone carving and all this, where these workers are more exposed to silicosis. This is personal monitor for breathing zone monitoring, which we have discussed, the 0.3 meter distance from nose or mouth. That will collect the respirable dust by these are the personal protective equipment this worker have to wear to avoid the ingestion or inhalation of silica dust. Other these are like wearing disposable or washable protective clothing at work site, shower if possible, and change into clean clothes before leaving, eating or drinking to be outside the dusty area, and washing hand and face which is must before that. Vehicle to be parked where no silica deposition. If any area exceeds permissible exposure level, put warning sign and mark their boundaries. Specific like those who are workers, like those who are working grinder, weight working, sandstone, milestone reading, will to be replaced with synthetic silicone carbide. Like mason and polishers, silica floral powder to be replaced with non or less fibrogenic polishing powder like bromide, zircon or polymer. And weight working, like weight cutting, using the machines and avoiding the minimum distance from them. After that, in miners, hollow drill to be used as positive ventilation and waiting period we can implement. After that, in pottery and refractory making, silica floor to be replaced with less fibrogenic material as anti-sticking powder of the pots. The refractory bricks lining furnaces to be replaced with heaviside matte chrome, dolomite or high alumina ones. Automation, machine learning and other use of modern technology to be incorporated. Like if we use automated machine, then we have to we can avoid the exposure, direct exposure. After that, molders and pelters, casting material of silica sand to be replaced with green sand blasting to be replaced with steel swords, binders and separator to be used to get clean and smooth casting, use of artificial intelligence, innovative technology. After that, recommendation, silicosis or pneumoconiosis elimination program covers health promotion, personal protection, diagnostic criteria, preventive measures, symptomatic management and treatment, and in last, rehabilitation. And implementation of NHLRC report on silicosis in later and spring. So, my personal request to those who are working in mines or those who are working in silica, where the exposure of silicosis or silica dust is more, and mainly it is concentrated on unregulated, because those who are regulated factory, there is already there is some standard they are following, but those unregulated factory, there is no standard at all, and they are having more exposure. They are not using any personal kind of equipment also. So in that area, awareness should be spread. So I am requesting from this month to DGMS, NIOH and DG some research work should be done to those unregulated factories and those even to those regulated, how much personal protective equipment they are using or they are wearing and how much protection they are getting, and whether these are implemented at their official side or not. Means sometimes what we see or what we see, rules are there, but people are not following them. So implementation is more essential. So, and we are conducting one course also, like AMIS, in that person or doctor who is working there, they should be trained in industrial health. Then only they can take a more effective things. So thank you very much. And these are my references, pictures, and content taken from our eminent Veerupai sir, Dr. Jugal Kishore sir, and our own sir, those who are dignitary and previous speakers. Thank you.
Thank you very much, Dr. for the next presentation. Now I invite questions from the audience. Any questions? Am I audible? Now I think. So now I request the audience to ask questions if you have any. I think we have no questions from the audience.
Thank you.
Thank you very much.
Okay. The silicosis is the issue. Yeah. How to prevent in the mine area? What is a preventive mechanism?
What's it?
अभी प्रिवेंशन कर सकते बोल रहा सिलिकोसिस है
Yes sir.
उसके लिए कैसे मैकेनिज्म हम लोग माइंस एम्प्लॉय के लिए लेके आ सकते हैं कुछ आइडिया है थोड़ा बता सकते
सर उसी के लिए मैंने बताया कि जैसे आप उनको रेस्पिरेटर प्रोवाइड करवा सकते हो, मास्क प्रोवाइड करवा सकते हो, फिर जहाँ पे डस्ट ज्यादा हो रही है वहाँ पे आप ऑटोमेटेड में जो मशीन है उनको यूज कर सकते हो, जो एडवांस टेक्निक है उनको यूज कर सकते हो, या फिर जो आप वेटिंग पीरियड है कि भाई जिस टाइम डस्ट ज्यादा है उसको सेटल होने दीजिए, पहले वेटिंग पीरियड को कम कीजिए उसको या बढ़ा सकती है, और जो एक्सपोजर है उसको आपको कम करना है कैसे, तो आप उससे डिस्टेंस भी मेंटेन कर सकते हो। एक है कि आप एकदम पास में रहोगे, अगर डस्ट उड़ रही है तो सीधा आपको इनहेल कर रहे हो आप उसको, तो वो आप कर सकते हो। लाइक सिंपल फिजिकल प्रिवेंटिव मेजर जो आप अपना सकते हो वो कर सकते हो, या फिर आप मशीन की हेल्प ले सकते हो कि ऑटोमेटेड अगर आपके पास मशीन वगैरह है तो आप उसकी हेल्प करके जो एक्सपोजर है उसको रिड्यूस करना है, सीधी सी बात है।
ठीक है।
थैंक यू।
Thank you very much, Dr. Pradeep Paswan.
I think no more questions. Thank you, Dr. Pradeep Paswan, for our wonderful presentation and very enlightening. To honor your expertise and your presentation, which you have shared with us, we would like to honor you with the Justice of Manito, handed over by your chairperson, Dr. D.P. Mandal. Please come to the center stage. Thank you. Here we come to our first session. Actually, we are now behind up 3 papers. So, we will directly go to the first session from here. Thank you, Dr. Mandal, for your chairmanship. And our next session will be on practice of occupational health in the industries. Our first speaker will be Dr. Devashish Yogi from WCM. And to chair this session, I would request Dr. R.R. Tiwari, Director, National Institute of Research in Environmental Medicine. Dr. Tiwari, please come to the desk. With the constraints, we have reduced the time of each paper of 15 minutes, please. Okay. After 15 minutes, before that you will get a buzzer. Please try to conclude by 15 minutes. Dr. Tiwari, Dr. Devashish Yogi, I will read out his introduction. Dr. Devashish Yogi is a medical graduate from Calcutta University and Associate Fellowship in Industrial Health from CLI Mumbai. CLI Mumbai and Kolkata. He has also undergone 3 hospital administration from AIMS New Delhi and Safety and Health Management. System audit executives. Development of program from IIT ISM Dhanbad and certified auditor for mines in WCL as per the guidelines issued by Ministry of Health. Joined Western Coalfield Limited, a subsidiary of Coal India Limited, on January 1995. He has a rich experience of about 30 years in the field of occupational health and currently posted as Chief Medical Officer Occupational Health and Nodal Officer Occupational Health in Western Coalfield Limited, Nagpur. Dr. Heath, please.
Thank you, Dr. Sarkar. Good afternoon, all. I'll straight away enter the domain of my industry, that is Western Coalfield Limited. This is a subsidiary of Coal India Limited. It is one of the 8 subsidiary companies of Coal India, registered under the Companies Act 1956. And it was conferred with Uniratna in the year 2007, 15th of March. We have 52 operational mines, out of which 19 are underground and 33 are open cast mines. This is the manpower details. We have a total manpower, including a contractual manpower, includes 45,105, and amongst that, the female manpower is also there. So total executive manpower is 2,101. Company-wise coal production, as you can see, that over the years there is an increase in the production with the demand needs of the country. And as far as WCL is concerned, it plans to mine more than 100 million tons of coal by the year 2026 and 27. Now we are also up to some diversification plans. The new business areas are solar power projects by CIL, the 2 thermal power projects by CIL, the joint venture project of HURL, the TFL Culture Fertilizers Limited. There are 4 surface coal gasification projects, 1 lignite to methanol project by CIL, and the coal bed methane project of CIL. Now we all know the father of occupational health. Now occupational health is the prevention and maintenance of workers' highest degree of physical, mental and social well-being of all occupation. It is that field of healthcare which deals with the safety and health at the workplace. The key aspects are early detection and management of health issues and prevention of occupational diseases, the statutory medical examinations, management of physical hazards, emergency preparedness and response, promotion of general health, compliance with legal and regulatory requirements, worker morale and retention, and promoting a safety culture. The importance of OH, creating a safe working culture, the improving reputation. The OHs can help an organization enhance its reputation, reducing absenteeism, supporting the health promotions, providing advice and counseling. Basic infrastructure, we have got 11 hospitals. Recently, 1 hospital has been added, has been upgraded. 1 of the dispensaries has been upgraded. We have 3 second hospitals and 8 area hospitals. We have 26 dispensaries. Casualty units are 10, and total bed numbers are 481. These are the respective manpower details of the various areas. We have got 10 areas. The total doctor strength is 180, officer specialists are 45. We have got 10 occupational health specialists and 23 other certified doctors. Now we are dealing with the initial medical examination as per my school and our own company's medical admin school. We have got area medical board, which is held at the headquarters level. The Apex medical board. The routine PME is done once in every 3 years for all our on-roll as well as the contractual employees. And we have also done the software for updation of the data to a non-editorial. Now these are the figures for IME. This is the figure for till 30th of November. This is the topmost figure is for the contractual employees who have undergone initial medical examination. And after that, followed by the departmental candidates. This is the PME target and performance wise. The total manpower 32,489. These are the targets. The PME done till November is 8796. Now we also have the vision testing for drivers and HMM operators, examination of workers involved in stable material and food handlers, the personal health counseling and stress management camps, the pit head welfare as well as the CSR camps across different areas amongst the projected affected people, the annual health checkup camp for executives, training and awareness, and occupational health survey as well as the occupational disease board which is held in the headquarters. Now, other than these routine medical examination, we have got some specific group of employees. The employees who are in the age group of 51 to 60 have to undergo yearly medical checkup at the OHC center or in a private hospital having proper facilities to category purpose to enhance physical and mental fitness and to improve safety awareness among those that group. Medical examination of identified persons or group of persons working at places or operation processes prone to generate airborne dust is done once in every 6 months. Now the special examinations which are included for employees are the annual examination for all executives, the chest X-ray and sputum AMP for employees engaged in food handling and stemming material activities, the stool examination for employees engaged in food handling, the eye refraction test for HMM as well as the drivers, the eye refraction test, and the annual examination for X-ray technicians in our hospitals. These are some of the clip shots of the personal health counselings that usually take place in our hospitals. The activities at PHED camps, the various PHED camps that have been covered in 2024, there are 51 PHED camps with beneficiary strengths of 3,508 and the departmental candidates of 350 and contractuals 1085. These are the welfare camps. The number of welfare camps in 2024 was 118. Total number of beneficiaries targeted were 7,000, more than 7,500. The CSR camps, number of CSR camps in 2024 was 85. The number of villages covered was 71. The total number of beneficiaries were more than 12,000. As I said before, the 10 doctors have been trained as in occupational health in our area and 5 more are awaiting the selection. There are 23 doctors who are ILO certified trained. The technical staff involved in the statutory medical examinations are also undergo the routine refresher courses every year. Now, occupational health survey, who are engaged in high, we had an occupational health survey this year. And we had a privilege of Dr. Sarkar who guided us, especially in WCL as well as in SCL also. In WCL we surveyed around 210 employees who were exposed to high level noise. Amongst them were short firers, the dozer operators, dumper operators, explosive carriers, and 57 cases of them were had sensory neural hearing loss and they were evaluated by Occupational Disease Board. 9 of them have been declared as confirmed noise-induced hearing loss, and those cases have been reported. Now, this is the ongoing NIHL survey at WCL. We were also a part of the safety and health management audit, and as per Ministry of Coal, all mines were supposed to conduct this audit with a team of mining engineer, your excavation engineer, E&M engineer, as well as the operational health specialist. This was as per the directive of MOC, and we had to conduct that audit for 52 mines. So, occupational health specialists were advised to look up the various dispensaries and hospitals catering to these mines. So that was a detailed game, and why do we require such an audit? Because it was a structured audit and with a risk-based approach. And we had to find out whether there is a system which is in existence in the mines, and whether that system was suitable or appropriate or not, or anyone who was using that system was knew about that system or the working atmosphere, what they needed to do and what not. Now these are the various elements which were covered, right from safety and health policy to planning for hazard and risk identification, assessment and control, the incident investigation, corrective and preventive action, management review and general requirements. The survey was conducted from October 5th to 13th of December. We had the privilege of certain studies that have been conducted in our minds by our own doctors, those occupational health specialists. On occupational health status of coal workers, pneumococcis in coal miners of Nagpur area, the prevalence of noise-induced hearing loss in coal workers in Chandrapur area, the cumulative traumatic disorders among workers working in Darjeeling and lastly at Manganese area, occupational health status of coal miners working at Mumbai area with special reference to occupational skin diseases, a retrospective cross-sectional study on metabolic diseases in underground coal workers, coal miners working in shift duties in bench area, dermatitis in coal workers, prevalence of musculoskeletal disorders in coal miners, prevalence of dyslipidemia among coal workers of Fani area, prevalence of noise-induced hearing loss coal workers in Maji area, a study on workplace medical examination for employees at Manganese area, and the occupational health status of coal miners working at Mumbai area open with special reference to work-related musculoskeletal disorders. Now, these are some of the glimpses of the first aid and rescue training that took place in our subsidiary. Now, what are the challenges in operational? We all know that no legislation exists to protect the workers, but there is incomplete, as my earlier speaker had also reiterated. There's an incomplete implementation of this legislation is a major constraint. Next, the lack of trained occupational health personnel, the qualification courses, training modules, the infrastructure, facilities, the budgetary provisions. Actually, in public health, very low budget is available. And a huge extent of undiagnosed and unreported occupational diseases. The lack of this is lack of due to the accurate information and data of the scope and extent of the occupational diseases. The infrastructure limitations, outdated medical facilities, inadequate equipment and technology, mental health challenges, the near revenues and the nature of work, aligning with legal frameworks like the Minor Acts and the international standards. What is the strategic approach for development? To upgrade our medical centers with modern medical tools, telemedicine capacities, mobile health units for remote locations, upgradation of vintage X-ray to digital format, monitoring of workplace exposures and implementation control measures, maintenance of digital records for employee health data, training programs for health professionals like GIH or FIS, and also the workers, the designated paramedics. Awareness campaigns to foster a culture of safety and wellness, and counseling services and stress management workshops. Extending health services to local communities, a matter of goodwill gesture. Now, foresight for the vision of the future. Integration of occupational health into the broader ESG, that is environmental, social, governance goals. Fully automated and integrated health monitoring system, comprehensive health benefits leading to higher retention, training and awareness regarding hazards and the importance of PPEs, preparedness for pandemics, as we have learned in the last COVID pandemic. In conclusion, that we continue to depend on the mining industry for resources, revamping the occupational health services is a crucial step forward, enhancing the well-being of its workers and achieving sustainable operational efficiency. The initiative presents an opportunity to address the existing challenges such as inadequate health facilities, lack of awareness about occupational hazards, and the need for a more robust health surveillance system. The path forward will require a multi-sectoral approach that includes investing in modern healthcare technologies, providing continuous training to health personnel, and implementing comprehensive health promotion strategies. Additionally, collaboration with various stakeholders, including government agencies, healthcare providers, and employee representatives will be vital for the progress. Looking ahead, Western Coalfield has the potential to set a benchmark in occupational health standards within the industry. By prioritizing employee health and safety, the organization can enhance productivity and foster a work culture, and helpful work culture contributes positively to the community and the environment. With foresight and commitment, WCL can transform its occupational health services into a model of excellence, ultimately leading to a sustainable and responsible mining operation and human industry. We hope to position WCL as a leader in the occupational health in the mining sector. That's all from me. Thank you all.
Thank you, Dr. Neogi, first of all, finishing well within time. Again, I am happy that WCL is paying a lot of attention on the occupational health and safety of the miners. Just want to have one clarification because now you are saying that you are finding the case of NIHL and they are being confirmed for the diagnosis of noise-induced and then they are being compensated. Just in 2015, when I was heading National School of Miners at Nagpur, we have publicated around and we have found around 70 odd cases of sensory loss in NIHL. So I don't know what happened because after that I left the institute and then the institute left the position and must be the Ahmedabad. So we do not know what happened to that because at that time I think it was only notified or not compensated.
Yes, true. As a part of NIMH, we are really missing NIMH because whenever we had issues, we used to just call the NIMH personnel at Body Nagpur and they used to come for this. Now NIMH has been merged to NIOH, so it's a very difficult job. We had recently, this survey was under the guidance of Dr. Sakra himself. So this is, what do we say, is the tip of the iceberg. Just we have isolated 10 confirmed NIHL cases. The rest of the 52, out of 57, 52 cases have been rehabilitated. Now, what we will be doing in the next coming February, we are re-examining all the rest of those 52 cases and we will again decide on the status of the NIH. Okay.
So that is why
that will increase, however.
That is why in your recommendation where you are saying that you want to have a state-of-art laboratory for chest X-rays, you should also mention state-of-art laboratory for audiometry and all because NIHL is a real problem in the mining sector.
I accept, sir.
Thank you, Dr. Neogi.
Excellent presentation. What I would like to emphasize upon this is that, as Dr. Tiwari has already told, that whenever we call some external agency and do a survey, health survey on any disease, there will be huge amount of opposition from the organized sectors. So it is better to start what we are doing now, in-house occupational health survey. Let us identify the tip, then we go down. Tip we have identified. Now, I think it is our job to do it in collaboration with some scientific agencies so that all other cases are done. Why I started with in-house survey is that because I understood. Earlier also we have done in Hindustan thing, the cases of our cases are opposed. Again numbers from 50 to 20, 20 to 10. It was like a bargain. It was not very scientific approach. So what I decided is that better approach is in-house survey. Let it be done by the doctors from the organization itself. And doctors should be properly trained, motivated, and made aware of the situation. In-house change is always a sustainable change. Somebody forcing it from outside, it is never sustainable. So now the tips we have identified, WCL is doing good work in operation health, along with simulating Colliers. ACCL is also catching up, but I don't think other subsidiaries of Coal India are coming to this extent. They have to catch up first. Any questions? Yes, please. Not even
NIHL cases, you have been identified. How you diagnose it? That is why only audiometry or there is conducted or
Clinical examination, otoscope, and audiometry.
so it has to be confirmed with audiometry also. BR test also.
They have also been done.
Yes, BR has to be done.
Done.
Okay, how it is compensation or is the mechanism of compensation?
In Coal India, we have to establish a protocol for compensating these NIHL cases. We have already forwarded a proposal to Politica headquarters and we are looking into it. And very soon we will be coming out with that proposal. How do we compensate?
Okay, you can share.
Sure, sir.
Dr. Ramesh, I would like to request you, if you have seen any compensation policy, you can share with them.
Yes, sir, we are having the one policy.
Please share with them.
Okay, sure, sir.
It is all same industry. Okay. Thank you, sir.
One question regarding NIH, sir. I have also seen so many cases of hearing loss, but I am unable to level it at NIH because NIHL, for NIHL there should be a long history of high noise exposure, there should be a characteristic known at 4,000 bar, and so many things. Safety officer argues that, sir, noise की वजह से noise at workplace की वजह से इसका hearing loss है या noise due to other source है, ये आप कैसे confirm कर रहे हैं? Second thing, there are some patients who are taking anti-TB drug, उसके side effects से noise का loss हुआ है, hearing loss है, तो उसको आप NIH में डाल रहे हैं. कोई आदमी high noise एरिया एरोड्रम के पास बता रहा है, उसका hearing loss उसको आप NIH में डाल रहे हैं.
What your doctor name, please?
Dr. S.D.N. Sharma. From UCL Jaluna.
Instead of Dr. Neval, I would like to answer your question. First of all, we are not going to be guided by safety officers and others. We are doctors, we will diagnose a case, we will confirm the case. Safety officers, mines management have their own way of thinking. They are right on their way. But first of all, we have to identify the case. That particular person is suffering from NIH. Then that matter will be inquired upon. How this has happened? Nowadays, we are inquiring each and every case, or maybe a group of cases. These are NIH. NIH diagnosed in a company does not mean his organization is responsible. Just like we inquire into fatal accidents, we inquire into occupational diseases also. And if that person was residing in a place where there is a neighboring high noise producing apparatus or high noise producing industry, all these things can also cause. But for that is established, then the organization will not be held responsible. Problem is that the management side, safety officer and all things, if there is a nature case, somebody in the management will be hanged. It is not so. We are detecting the case for his benefit. Person is suffering, whether it is outside agency, inside agency, whatever it is. Person is suffering. The person has to be rehabilitated and compensated as per law. But who is responsible? Responsibility fixation will come only the matter is inquired upon. That the doctor cannot decide. Doctor will say the case is due to this. As per the clinical protocol, as per the diagnostic protocol. He will diagnose and confirm the case. But why it has happened, that is not his answer to be given. That matter is to be inquired upon. Then only the reply will come. Am I able to clarify you?
No, we can level at a case of hearing loss. But hearing loss.
Noise-induced hearing loss is a typical disease. Typical disease. The person who is trained in that, he knows.
When we
are you qualified to occupational?
Yes, sir. I am certain.
Then I think you should be able to know it is very well demarcated. You can very easily point out as an agent.
When we refer a case of hearing loss to a
it will not be always copybook pattern. It will not be always copybook pattern. You have to correlate with this hazard exposure also. Hazard exposure and with the typical mark and so many other things also. You can identify level the case. But why it has happened, that is not the doctor's to decide. That is not mine or your job to decide. That will be inquired upon and then finalized. Dr. Shidati.
I just want to supplement what Dr. Kaushik is saying. There are already set criteria, already set criteria prescribed WHO regarding water damage. And in difference of 30, there is certain frequency on which they are not at 4,000. And there is a difference of 30 decibels from the 500 frequency. There are already set criteria. I don't remember exactly. And number two, you must separate out two things. One is the diagnosis part, one is the compensation part. Compensation is only paid for the loss of hearing. And every NHL case
it doesn't have to be compensated. That will be calculated. That is calculated. So I mean, this fear of that somebody is going to be hanged every time one single case of annihilation detected.
No, responsibility fixation comes later. If but that is also fact. If somebody is responsible, action has to be taken. For matter accident, also we are taking action. So for NIH also there may be actions if somebody is held responsible, sheerly and squarely held responsible for somebody's disease. That the law will take its own course. But that is nothing to do with the diagnosis. I think am I clear? Any other question?
No. Actually, the software that we are using at WCL, that doesn't allow us to have one for 3 years and one for 5 years. So it was decided in the year 2015 that for all employees of WCL, we'll do it once in 3 years.
Okay, sir. Same we are practicing, sir, but as rule says 45 and below.
Yes, that's true.
We are increasing non-communicable diseases like diabetes, hypertension, complications like stroke, heart attack, etc. So
that you can suggest. See, once wastage code comes, it will be once in every year.
Once in every year, yeah.
Wastage code, it is anytime it may come in vogue, so it will be once in every year. I think we are concluding this particular presentation, and thank you, Dr. Yogi, with recognition to your expertise and sharing the paper with us. We will comment with the piece of matter. Chairman, sir, please. Memento, please. We'll hurriedly go to the next paper, please. Dr. Gautam from Israel. Please come for the session. Dr. Deepak Kumar Gautam is MBBS and FH. Done a project study on lifestyle-related disorders in mining workers in 2012. Delivered lectures on environmental and occupational health hazards in mining industries, ergonomic hazards in mining industries, detection and prevention of silicosis, first aid in mines, etc. Received prestigious Indian Achievers Award 2023 for excellence in healthcare, for contribution in occupational health and clinical care. He is at present CMO, Hindustan Zinc Limited, an occupational health specialist with 15 years experience in mines and 18 years post-qualification experience. His paper is Occupational Health Practices in Mining Industries, Challenges and Way Forward. Thank you.
Gautam, if you can go favor to the house by using 10 minutes so that they learn in not today.
10 minutes is too early.
Okay.
I have to finish in 15
Right,
minutes.
please.
Good afternoon. I will quickly, I will try to quickly complete my session. So, introduction part is done by Kaushik Sarkar, so I am not going to say about this. Now, the definition of the occupational health is also said by previous speaker, and these are some principal approaches of the occupational health like ILO Convention number 161, Recommendation number 171, Factory Act, Mines Act, Mines Rules, and very important recommendations of the National Conference on the Safety of the Mines. Then present scenario of the occupational health in India. It is estimated an annual 36,700 fatalities, 1,83 lakh injuries and 18,50,000 diseases related to the occupational health. But the problem is that of countries more than 500 million workers, only less than 10% of are covered by some health and safety regulations. This is the main problem. And if you compare with the developed countries like USA, where occupational medicine is super specific since last
I think doctor will go by what you are practicing in your area.
Yeah.
It's a generalized topic. Huh?
Okay. Now this is all session in India mining. Then these are some occupational health hazards in the mining industry: physical, chemical, and biological. Then these are 8 notified diseases in the mines: pneumoconiosis, silicosis, asbestosis, manganese poisoning, noisy staging, those contact dermatitis, pathological manifestation due to the radioactive substance, occupational cancer. Now injuries. Mining is a very prone industry for the accident, so the injury management program should be there as a part of the workers management. Then benefits of the occupational health and safety: decrease human suffering, decrease absenteeism, increase the productivity and quality, decrease the medical cost, decrease the insurance cost, decrease compensation, and decrease the validity. These are some general functions of the OHS center. I am not going to tell about this because it is already covered. It is curative and preventive. Then medical examination, it is a plant meeting between an employee and an occupational health professional. These are the frequency as per the DGMS. 45 years of the age, below 45 every 5 years, above 45 years of age every 3 years, and above 60 years of the age every year. Then occupational health surveillance, it is important thing. It is the systematic collection, analysis, and dissemination of the disease data on the group of workers and is designed to detect early signs of the work-related illness. I suggest and I emphasize that occupational health surveillance is a very important tool for the occupational health management. Now, this is USA's hierarchy of the HR control, like engineering control, administrative control. PP should be the last tool, not first tool. Now, 2 topics I have covered, but I will not take much time because dust silicosis, it is said by so many speakers, so I am not going to cover this. This is the typical pictures of the silicosis industry, and 1% is the silicosis. These are types of the silicosis: acute silicosis, chronic silicosis, and accelerated silicosis. Then diagnostic criteria. Then these are some chest X-ray of the silicosis. One case study of the silicosis in the DOSA in the 2015. एक worker जो stone carving industry में 18 months से काम कर रहा था, mainly engaged in the grinding of the sandstone. History of the breathless after 2 years. Then उसको severe breathless develop हुई, private hospital में admit किया. Then had multiple episode of the pneumothorax, and within 9 months of the treatment he expired. Now treatment of the silicosis, there is no clear-cut treatment of the silicosis, but recently various polymers like polyvinyl, pyridine, and oxide have been evaluated, but it is not. Results are uncertain. So prevention is the best way for the protection from the silicosis. Now these are some prevention criteria like use of water, good ventilation, wet drilling, reduce dust mask. Then prevention of the silicosis, like replacement medical examination, we have to evaluate the person with a chest X-ray and spirometry test. Then training and others. Noise stereotypes is also very important notified disease, and I'm not going to the definition of the NIHL. It is very simple definition. Hearing impairment resulting from the exposure to the loud sound. Right? So characteristic of the NIHL and other things. But one thing, one person was telling that NIHL है ये कैसे पता चलेगा? Actually एक बहुत बड़ा gap ये भी है कि ideally audiometry should be done after 24 hours of the rest, but it is not being done in the industry. Normally night shift है, दूसरे दिन आके PM कर रहे हैं, audiometry हो रहा है, तो कभी diagnose होगा ही नहीं. So on the basis of only one audiometry test, it is not possible to cover and diagnose the NIHL. So history-wise, exposure-wise, it is mandatory to detect. Maybe possible repeat audiometry is also suggested. These are some non-auditory effect of the noise, auditory effect of the noise, and it is the standard draft of the audiometry in the NIHL. These are some hearing conservation program, noise measurement, noise control, identification of the susceptible individual in the replacement medical examination, and then in the PM. Isolation criteria as per the AAO. अगर 2 PM में 10 decibel का shift आता है, तो आप उसको जो protect करना चाहिए for the low noise area. These are some ear protectors, ear plugs and ear muffs. Health education and awareness program for the employees. Now, I'm taking the opportunity to
present some practices of our industry. Kaushik Sarkar sir came to my mines in 2012, and then Sisodia sir also came to Agucha mine in 2015. But sir, from there we have come forward a long way. It is a big industry of introduction of the Agucha mine. It is the world-class mine where world-class technology are followed. 5,000 to 5,500 workers permanent as well as contract, including 200 to 300 experts from the different countries are working. Company is having a very good focus on the health and safety, certified in the ISO 9001, 14,001, 45,001, 50,001, having very stringent policy for the HSE at company level, having Vedanta sustainability framework, where occupational health is one of the very important areas. Annual external audits by global agencies are being done, and performance is reviewed at CEO and chairman level. Periodical internal audits are being conducted. Now, these are the infrastructure by occupational health services at Nigeria. Every unit is having 10-bedded hospital at every site, and all basic infrastructure like ECG, X-ray machine, laboratory, audiometry, spirometry, pharmacy, physiotherapy room along with the full-time physiotherapist, AED machines and emergency care equipment with the trained doctor and staff. These are some pictures, like it is well equipped and very highly technological labs are there in the Agucha mine and other sites also. At every site, agile, well-equipped ALS ambulance, advanced life support cardiac ambulances are there at the mine and at the colony also. And one very good initiation was done at underground mine of the Agucha mine. That underground ambulance station is developed at Rampur Agucha underground mine, which is very good initiative and first time in the underground mines in India. A well-equipped ambulance is stationed there along with the trained nursing staff on the clock for emergency care. Normally क्या होता है underground mine में कभी भी एक्सीडेंट होता है तो उसको ऊपर आने में 20-25 मिनट लग जाते हैं. तो it was very good initiation. तो एक जो टाइम ऑफ अटेंडिंग द मेडिकल पर्सन है वो कम हो गया है और वहीं पे आपको एक फर्स्ट एड मिल सकता है, इसलिए हमने ये इनिशिएशन किया. नाउ इन 2022 Ajit has done a very good project. साइट पे हर साइट पे कार्डियक इवैल्यूएशन किया गया है हर वर्कर का, इंक्लूडिंग कॉन्ट्रैक्ट एज वेल एज परमानेंट वर्कर. राइट नाउ कार्डियक डिजीजेस आर वेरी प्रेवलेंट इन इंडिया, सो every worker was covered. So many people were diagnosed with the cardiac disease. Treatment was done by the Ajit only. So many persons benefited. Surprisingly, very young people also detected with the cardiac disease, and they were benefited. Now, DGMS approved first aid training center where certified training of the first aid is being given to workers. Very well developed RT room where basic training is being given to workers. Female workers are getting trained for the first aid and rescue, and first time in India, first all India women rescue team from the Ajit participated in all India mines rescue competition in 2023 and received first prize. And that is very proud thing for the Ajit because diversity is being encouraged in the mining and in the rescue also. Recently, all women rescue team of the Ajit participated in the international mines rescue competition in Colombia and won laurels for the organization. And recently, this year also, in the All India rescue competition, female team of the Ajit participated and got the second prize. These are some things like biological monitoring, workplace monitoring, training, advisory, disaster preparedness, record keeping, and all other than PP, replacement medical exception, PME, study, work environment, and effect. Yes, one thing I would like to tell, recent advancement in the occupational health and industry hygiene studies. Right now, since last 7 years, Hindustan in emphasis on industry hygiene, engaging industrial hygiene specialists, covering the occupational health professional for the industrial hygiene training by the coach. The thing is that कि आपका जो occupational health parameters है, उनकी monitoring कि वो above TLP या below TLP है, अगर है तो उनको identify करना, red zones, वहाँ के workers को agent similar exposure group आपको identify करना, उनकी frequency of the monitoring, audiometry, spirometry बढ़ानी है, ताकि आप उनका health assessment कर सकें. Then these are the pictures of some work zone monitoring, like illumination survey, diesel particulate matter, noise survey, dust survey, air gas monitoring survey, and humidity survey. Way forward, biggest challenge for the occupational health is unorganized mines, where very little work is being done in the field of occupational health. So more focus is required in unorganized mines. More awareness is required for importance of occupational health and its benefit, because healthy workplace and healthy workers make any organization more productive. Government should take initiative for making compulsion for giving importance to occupational health on real ground. Implementation of the regulations related to occupational health need to be monitored more frequently and in depth. Engaging more occupational health professionals in the mining industry, changing of the frequency of the PME can be relooked every 3 years in the workers of age group of 45 years and below should be changed to every 2 years, and in the age group of the 45 to 55 years and every year in the age group of more than 55. As procedure said, OHS code आने वाला है, तब तो already annually हो जाएगा, पर जब तक के लिए it can be relooked because 5 years frequency is too long. And अभी जो current strategy है या current trend है disease का, उसके हिसाब से थोड़ा frequency change किया जा सकता है. Then promotion of the industrial hygiene, क्या है कि बीमार होने के बाद में आप बहुत हद तक उसको prevent करोगे, but आप अगर industrial hygiene से prevent करवाते हो, आपका work zone monitoring होता है, personal monitoring होता है, तो आप hazards को पहले से identify करके उनके लिए preventive measures like engineering control, administrative control, PPs ये आप implement कर सकते हैं, तो हो सकता है कि disease की नौबत नहीं आए. Then in the end, in the last, prevention is always better than the cure, and occupational health disease can be prevented only and cannot be treated. So with the good occupational health practices, it can be prevented. Mining is hazardous industry, we know, but mining तो करना ही है, because mining is a very important sector for any country's growth. किसी भी country की growth के लिए mining तो करना ही है. तो हमको क्या करना है कि taking care of the good orchards, we can do safe mining, and it is the responsibility of employer as well as employee also. हम हमेशा employer को blame नहीं कर सकते. कई बार क्या होता है कि वो सब कुछ देते हैं, PPs भी देते हैं, training भी देते हैं, but employee का behavior प्रॉब्लम भी होता है. वो कभी खुद नहीं लगा. So it is the responsibility of the employer as well as employee. So with this, I try to highlight some points of the occupational health of the mining and our good practices in the Hindustan Zinc Limited. मैंने बहुत बार सुना है कि जय सुरक्षा, but as an occupational health professional, I would like to say जय स्वास्थ्य, जय सुरक्षा. Thank you so much.
Thank you, Dr. Gautam, for a nice presentation on occupational health and the work you are doing in your industry. Just a suggestion, because you have said that you have moved out, all these are voluntary and self-certification, you have all ISOs, and you say that you have a lot of good occupational health setup. You should have gone for USHAS, which is more pertinent to occupational health, because ISO is for environment and safety more rather than safety. So you should fight for OSHAS also.
Sir, I just wanted to tell you that we are following the ACGS guidelines in our industry for the occupational health monitoring, for the PME guidelines also, that is very much useful. Yeah, standardization also, but for our sustainability framework, for most stringent guideline we are following also, and that is what it is.
Thank you. Any question? I think we can take 2 questions.
Hello, I'm Dr. Kaushik Shukrata, ENT surgeon from SSCA. In the earlier part of the presentation, you mentioned that noise-induced hearing loss cannot be diagnosed. You only need like noise exposure, once an X-ray has to be done, audiometry and all that. I'd just like to add one thing here. That whatever you're telling is about sudden sensory neural hearing loss from acoustic trauma. Okay, so acoustic trauma is a sudden incident, and suddenly the next day patient will be telling that they are having an ear block. Typically they will be telling ear block sensation is there and he will not be hearing. Noise-induced hearing loss is a chronic exposure thing. It will not develop overnight. And it will regularly be only caught in repeated audiometry, which you mentioned. So whatever you told that next year audiometry has given, that component specifically I am just telling, that is about sudden sensory hearing loss, and it is not related to noise induced only, like the occupational exposure. You can happen in patients exposed to DJ and during marriages or from flights also, who stand near the propellers. Okay? Okay, thank you.
And occupational health diseases जो है उनका एक अच्छा फैक्टर ये भी है कि ये एक दिन में कभी नहीं होती, इसको टाइम लगता है 5 साल 10 साल। तो अगर आप ढंग से प्रैक्टिस करते हैं तो इसको बचाया भी जा सकता है, प्रिवेंट भी किया जा सकता है। ऐसा नहीं है कि एक ही दिन में हो जाएगी, 5 दिन में हो जाएगी, 10 दिन में हो जाएगी। सो द गुड फैक्टर आल्सो है कि आप इसको टाइम मिलता है, आप टाइम टू टाइम इवैल्यूएट करेंगे तो आपको टाइम मिलेगा कि आप इंजीनियरिंग कंट्रोल, एडमिनिस्ट्रेटिव कंट्रोल एंड ऑक्यूपेशनल हेल्थ कंट्रोल भी कर सकते हैं।
ये जो डॉक्टर सुब्रता बोला है इज वेरी पर्टिनेंट थिंग. Instant, that is the transient hearing loss is something else and a chronic effect is something else. What he clarified is very pertinent. Yes. And I think it was for everybody's consumption. And आप तो बोले occupational एक दिन में नहीं होता है, ये एक अच्छी बात है जब कंट्रोल कर सकते हो. लेकिन प्रॉब्लम ये है occupational एक दिन में नहीं होता वो करते कोई ध्यान ही नहीं देता. ये क्या दस बार नहीं. What I told him, what you told him, safety or health का जो problem है वही problem है. Safety आज एक्चुअली होता है. When I joined the DGMS, my DD Mr. Bhaskar Bhatt is no more now. बोला मैं तो 10 साल बाद सिलिकोसिस जरूर कि हम मेरे को बेटा है उसको देखो. And he was very right. So that is sometimes a problem also. Anyway, very good presentation. One more question we can take. Please.
कंपनी है, कंपनी अब सही बोल रहा है. कितना क्या अभी तक सिलिकोसिस हो गया? आपका फीडबैक मैनेजमेंट में क्या है? कैसे रिड्यूस कर रहा है उसमें? हर साल में क्या ड्रॉप डाउन हो रहा है, कैसे हो रहा है?
सर, आपके क्वेश्चन का जवाब मेरे पास ये है कि apart from the other good infrastructure what we are following, मैंने जो आपको एक बात बोली कि इंडस्ट्रियल हाइजीन जो है वो आपका वर्क प्लेस मॉनिटरिंग है और उसके हिसाब से जो हम पहले से मतलब एक स्टेप पहले से आपके एरिया आइडेंटिफाई करके वहाँ इंजीनियरिंग कंट्रोल लगाना, एडमिनिस्ट्रेटिव कंट्रोल लगाना. So that's why since my tenure there is no record case of the silicosis and in 2015 or 16 Dr. George Jones साहब हमारे यहाँ पे आए थे, उन्होंने साइंस में स्टडी किया and no case of the silicosis was there.
अभी तक ये एक आदमी नहीं साहब आपका कंपनी में
अभी लास्ट 13-14 ईयर से जब से एसोसिएटेड हो सकते नहीं है and previously जो एक सिसोदिया सर ने दिखाया था प्रेजेंटेशन वो शायद पुराना एक जरूर सिलिकोसिस के रिपोर्टेड केस है.
अभी प्रैक्टिस में फर्स्ट में आ रहा है 20% ह्यूमन माइनिंग प्रैक्टिस में आ रहा है.
Statistics, as per his statistics नहीं है because as we are discussing since the morning, diagnosis, bringing the sample and proper detection method, हर चीज में हम लोग को improvise करना है. ठीक है. So thank you, Dr. Gautam. So as in order to recognize your expertise and the sharing of knowledge, we would like to honor you with a piece of memento. Memento, please.
we start with the next speaker of the same session, second session, that is regarding the occupational health practices in the industries. That session we already had 2 papers. Now the third paper we will start with, to be presented by Santosh Kumar Chaudhary, Dr. Santosh Kumar Chaudhary. He is MBBS with AFI from CLI Mumbai. He has an experience of working in various hospitals like Community Health Center and Referral Hospital, Bhavnagar Government of Gujarat, Dr. R.M. Hospital, New Delhi, Dr. R.T. Enal Hospital, Guru Tegh Bahadur Hospital, New Delhi, and few other private hospitals before joining current industry. Currently, he is the Chief Medical Officer of JK Cement with a total experience of 23 years of field. Dr. Chaudhary, please start.
Good afternoon. Good afternoon. Good afternoon, everyone. Before we explore into the critical role of occupational health in securing the future of mining industry, I would like to start with, because we have a very less minutes to speak. Most of the time, within 15 minutes, I have to close the session. So I just start with the importance of occupational health in mining. Mining is a hazardous industry with inherently risk to various exposure such as dust, noise, heat stress and accidents. OH is crucial to protect the lives and well-being of miners. A strong occupational health culture can lead to increased productivity and reduced costs. Next, OH compliance is essential to maintain a positive social and environmental impact. So, what are the common occupational health challenges in mining industry? First and foremost is remote and isolated work environment, which can lead to suffer timely medical care and mental health support in remote locations. Second one is exposure to hazardous substances. These might be dust, heavy metals and explosions. Next one is psychological stress and fatigue. Long hours, shift work and isolation work can lead to stress and fatigue, which can also impact on overall workers' performance and of course health. Next one is substance abuse. It's also negative impact on safety, productivity and of course overall health. Lack of awareness and training. It can lead to accident and exposure of health hazards. Next, some of the best practices in OH occupational health can help us to create a safer and healthier environment are: first, number one is a strong leadership and commitment from management. Top level management is very important for occupational health initiative. Effective risk assessment and control measures. That should be Next one is fitness to work evaluation. Timely initiative and preventive aspect to occupational health hazards. Next one is emergency response planning and training. These are required regular training and ensure to improve preparedness for mock drills. Quick emergency medical response. Timely and effective medical care is very important because of the remote location. Next one is health monitoring and surveillance. Means routine medical checkup where we can find whether there is any changes, early changes, we can just intervene and guide properly. Next one is diagnostic tool, pulmonary function test. One of the key diagnostic tools in occupational health practice is the pulmonary function test. And we always talk about more FVC FEV1 and FVC FEV1 ratio. Of course, these are very important tools to diagnose obstructive or restrictive type. But here I would like to more emphasize over FEF 25-75% because for preventive aspect to detect early changes in a small airways is also important as a occupational health physician. So if any changes indicate in FEF 25-75, we can early detect and closely monitor the person and act accordingly. Next one. If FEF 25-75% is less than predicted value, what steps should be taken? We should repeat PFT to ensure about changes for overall lung health over time. General examination, sign and symptoms to rule out acute respiratory infection for lung function. Next one is history. History is also very important. If a smoker motivated to stop smoking, it can lead to indicate some changes in PFT. So again, encourage physical activity to improve lung health and lung function. Next one is monitoring. Special attention at the time of PME. If you can get any type of changes in FEF 25-75%, we can closely monitor the person and do what conditions are I have already mentioned here, then acknowledge what to do next. Next. This graph represents my observation based on randomly sampled of occupational health status in 50 mine workers. The age distribution reveals that 48% of prime worker class are between 41 to 50 years and 36% are experienced bracket of 31 to 40 years and 16% are younger talent. This sample is based on experience and younger talent, which I can just, these are my some observation, which I just would like to explain here. Next one, their body mass index, which among that 50 workers, I found 20 workers are having more than normal weight. Out of that, 10% are obese. This is also a significant number which can especially can lead any health issues. We can monitor these issues. But good one is rest 60% are normal weight. Next, substance abuse. When substance abuse, also known as substance use disorder, when collected data, 19 out of 50 were some form of substance abuse. Out of that, they are seriously impact on lifestyle diseases in and other aspect of occupational health too. Next one is spirometry finding. Through spirometry finding, I observed 10% of our workers had abnormal spirometry finding of early small airways disease. Identify the earliest stage is crucial for implementing preventive measures and early intervention to slow disease progression and improve overall lung health. Next, chronic disease distribution. Chronic disease distribution, a complex challenge with no single solution. About 21% of the elderly in India reportedly at least one chronic disease. Out of that, 17% elderly in rural areas and 29% in urban areas are having chronic disease. Hypertension and diabetes accounts 68% of all chronic diseases. Comparing that to our sample, 80% of our workers had chronic diseases, which was more prevalent with increasing age, suggesting a need for age-specific health interventions addressing chronic diseases are crucial for improving employee health and productivity. So, we have to act accordingly. Next, quick medical emergency response in mines, a complex challenge. Of course, I have already mentioned remote and isolated location. That is prime concern. Mines are often located in remote areas, far from hospitals and emergency services. It can cause not timely medical care and mental health support in these areas. Next one is hazardous condition. Mines can have dangerous gases, unstable ground, and other risks that complicate rescue efforts. Limited communication. Communication within mines can be difficult, especially during emergency, hindering rescue services, rescue effort. So, a strategy. The strategy we require for improved response time and save lives. A robust emergency plan. It should be developed comprehensive emergency plans tailored to the specific mine's layout and potential hazards. Well-trained personnel. Train mine workers in first aid, CPR, and emergency response procedure. Even in mass emergency, situation, they must trend the trials, must follow the trials. Next one is advanced medical equipment. Equip mines with a state-of-the-art medical equipment, including AED. Rapid evacuation system. Implement efficient evacuation systems to move injured miners to safe place quickly. Improve communication. Invest in reliable communication systems within the mine to facilitate coordination during emergencies. Collaboration with local emergency services. Establish strong partnerships with local hospitals and emergency services for seamless transfer of patients. Next is very important. Nowadays we are talking about mental health. Mental health at workplace. Mental health effects on mine workers is significant due to physical demand and hazardous nature of work. Potential mental health effects. Work-related stress. Long working hours, heavy workload and pressure can lead to stress. Depression and mood disorders. Isolation, loneliness, chronic health problems and post-traumatic stress can lead to depression and mood disorders. Cognitive impairment. Exposure to certain chemicals like lead, uranium and so on can lead cognitive impairment or neurotoxic effect. Personality traits. Certain personality traits can increase the risk of mental health problems like neuroticism means negativity trait can contribute risk of mental health problems. Next is mitigation strategy. We are conducting micro sessions, conducting short sessions on stress, anxiety and depression. Awareness flags and posters on mental health. But future steps we can take more to implement stress management and mental health programs, encouraging open communication and reporting of mental health concerns, offering access to mental health professionals and counseling services, promoting work-life balance and flexible work arrangements. So next, seasonal health challenges, especially summer heat stress in Rajasthan we found frequently. So I would like to mention here, despite rigorous safety protocols and awareness campaigns, heat-related illnesses such as dehydration and heat stroke continue to pose significant risk to our workforce. So here I can recommend to proactively protect our workers. A reliable tool for early detection is essential. So I recommend the use of a pain-safe urine refractometer can play a crucial role in early detection of dehydration. By regularly monitoring urine specific gravity, we can identify individuals at risk and implement timely preventive measures. Thank you.
Nicely highlighting the work which is done at and it is nice that even with small sample of 50, you try to find out or you try to analyze the data and try to find
Yes, sir, of course.
But then, because there is some contradiction in the risk factors like BMI, like age group, and the proportion of people having these type of chronic problems. So I think maybe we have to reuse the data.
Sir, actually we are having 275 or 278 workers in all mines, and we are having 38 persons are suffering from chronic diseases. So among them randomly we choose, but I think this is almost there. Maybe it is due to our regular medical checkups, maybe, but that is not, I have already mentioned that that is not a figure to national data, and even Rajasthan data also greater than this figure, of course, but this is a true data as far as that data is concerned.
So any questions from the house? Maybe we can allow few questions.
Sir, you are conducting the survey of the nearly 50 persons, but different age groups. But you are not taking the course of the service of the employees. That is the main motive of the service is important rather than age group. Because 21, 30 years you may not have anything, so everything will be normal. So if you take into the service, if you have minimum 10 years or 5 years service, I think it will be better. That is fine.
Yes, of course.
One more question, please.
Length of service.
Length of service. What do you think is length of service? That is very important actually. Not today, not in the Ramadan this time. It is important. Okay. Anyone has one more question you can allow? Anyone? Okay. So we conclude this presentation. Thank you, Dr. Chaudhary. In recognition to your expertise and sharing your views with us, we will honor you with just a piece of memento and you know by your session chairman, Dr. Rajasthan. So we come to the next and the last paper of this particular session, and that will be presented by Dr. S.K. Bhandari. Dr. Bhandari, please come to the dais with your presentation. Dr. Bhandari is MBBS and certified in Occupational Health and ILO classification, purchase radiograph. He worked in Rajasthan Medical and Health Services for more than 35 years. Along with he worked in Army Medical Services. He is currently the head in the Medical Services unit of KK Lakshmi Cement, Sirohi, Rajasthan, with a total experience of about 40 years in the field of medical and health. Please listen to Dr. Bhandari. There is some technical issues with Dr. Bhandari's session, so we will conclude this session. We will go to the next session till the problem is fixed. Technical problem is fixed. We will come to our last session where there are 3 papers with Dr. V.V. Mandal, Dr. R.R. Tiwari and Dr. Suman. For chairman of this session, I will request Dr. P.K. Chichodia to come to the dais and chair this session. This will be a very important session. All experts in their own fields will be speaking in this. First, I will call upon Dr. V.V. Mandal to present his topic followed by Dr. Tiwari and Dr. Suman. A brief introduction of Dr. D.V. Mandal. I had to make it brief actually. He has a very long introduction. He holds bachelor's degree in mining engineering and MTech in mining engineering with PhD. Dr. Mandal has 22 years of experience in underground mechanized metal mining. He worked in Hindustan Copper Limited, Sikkim Mining Corporation, and worked as a deputy director in National Institute of Miners of Nagpur under Ministry of Mines. He has a vast experience in conducting and coordinating research on environmental and occupational health hazards faced by mining community. He has also conducted pioneering research on equipment-induced human vibration in mining industry and widely published his research on noise control and human vibration. His topic is risk evaluation of equipment-induced human vibration, principles and practices. Let us listen to Dr. Mandal.
Hello. Thank you, Dr. Shankar, for a nice introduction. Very pleasant good afternoon. I will be talking about the exposure to vibration at workplaces and its some mitigation challenges for the developing countries. We have been working on this vibration since 2005, starting in National Institute of Miners here. And there we started conducting studies on the vibration exposure characterization, how the our machines and the working places are performing with respect to human vibration. Equipment-induced vibration, because see, we are talking about vibration, so it may be confused. Some people will be confusing is whether it is related to blast vibration or not. So it is distinct thing. I mean, it is basically equipment-induced vibration that is transmitted to the human body from any route. Either say for jackhammer operators, it is through the hand-down system when you are holding the handles. So the hands are vibrating and it is going to the hand-down system. And for whole body vibration, it is primarily transmitted through the seat and body interface, and it is going to the entire body. Also in a standing posture, whole body vibration can occur. We just calculated from some randomly from some master roll and found that about 20% people are subjected to that. It will vary from time to time, and in days when we are having the mechanization, so definitely the number of machines in use are very high nowadays, so the population will vary. This is a preliminary estimate in 2006. The concept of human vibration is based on the resonance characteristics of different parts in laboratory condition. That means a sitting person or a standing person is being excited with a stimulus given through a machine, and when the response is received from that subject, we are recording it. So these are average values of the response that we get in different postures. And when the person, when he can, for a particular frequency, can go on increasing the amplitude, that is the amplitude of acceleration. If you do that, at certain point of time, the person says I am having some discomfort. That level is actually recorded for thousands of people. So from there, we have summarized this. Actually, there is a range, and depending on the weight of the body and the construction of the person, human body, these frequencies and resonance will definitely vary. When start with hand vibration, high magnitude of this vibration, high magnitude is the oscillation. If it is high, and that I say, or what is called high and which is low, we have two different types of two broad categories of effects. First one is the muscular, well known as Raynaud's disease, and vibration induced white finger or dead man's hand. The other part is neurological and musculoskeletal part. These two are distinct, and sometimes they can occur, and both the things can occur also at the same time. Dr. Dasgupta and Dr. Harrison from UK in 1986 conducted a study in Rourkela, limestone mines, where they said that the vascular symptoms are very rare and rather the neurological symptoms are prominent. Same thing we got from South African mines, and we got to conclude that since it's exaggerated or exacerbating in presence of cold and smoking, so chances of getting the vascular or white finger will be very, very less. But neurological symptoms will be more in tropical countries. The adverse health effects can be categorized like this, different things. I will not go into the details. I already shared this with this PPT. This is a typical picture of vibration white finger, and can you get there? Yeah. So the disease start whitening from from the tips mainly, and also one or two spots in the palm, and then it gradually spreads to the all and the entire hand also later on. This finger clenching effect is basically due to the transient, the blood vessel spasms due to vibration, because it does not coincide with the rhythm of blood flow, natural blood flow. So it creates obstruction due to a mismatched oscillation stimulated by the equipment vibration, or say jackhammer in our case. So the blanching starts going and then it spreads. And there are other effects like the neurological part, which you doctors will be better appreciating easily. And here the sensory neural symptoms are they can be measured in touch, temperature, reduced tactile discrimination, all this standard practice, which has been recorded or well stipulated in ISO 5349 Part 1 in 2001. Also it has been republished in 2004, same standard. This is the standard which is providing guidance for the hand-arm vibration. Now these four parameters are equally important for whole body vibration also. That is the intensity, magnitude, and then the frequency, at what frequency we are getting the vibration. The duration means how long you are getting the exposure, and also cumulative exposure to date. That means how many years you have been exposed in that. That means the occupational history is equally important here. Hand-arm vibration is measured in 3 axes. Like whole body vibration also, we have 3 axes of measurement. That is X, Y and Z. So these 3 axes, we have accelerometers which can record the vibration in all 3 directions, and that can be processed in vibration meters, and you can download it and see how strong is the vibration and what are the frequency components in the vibrations. Root mean square acceleration is the basic parameter by which we quantify the vibration. We take the acceleration and over a time period we get a root mean square value. Now in case of hand-arm vibration, since it's a very a small system for study, so the X, Y, Z, these directions are not separately evaluated. So what we do that we take the vector sum or root over x square plus y square plus z square as a single value for the purpose of evaluation. But recently, some scientists have, of course, they have derived a special parameters called the lifetime dose, where they have included the number of days they are working and the number of years they are performing the same job. This one, number of days in a year, number of years. So this is a complete lifetime dose which can be used for the purpose of evaluation of the risk. As usual, all exposures are transformed into 8 hours time weighted average value. So that we transform using this formula, which is A8 equal to 8. This is the x square plus y square plus z square and root over this part. And this is the standard reference of 8 hours, and this is the actual exposure. If somebody is operating maybe only 4 hours or 3 hours or 6 hours for let's say dumper operators. In that case, we will be using this thing to transform the entire the things in a common term, so that we can compare our results with the international studies. This is one model which is very popular, because in Europe and US and Canada, these places where the climate is quite cold, so they have rather on priority developed this model where we use this formula called this dy. This is the dy is the group mean total duration in years, and A8 is the value that we have derived in the previous slide. So if you draw it from here, you can find out the from the equation shows the daily vibration exposure for 8 hours, which at an estimate produces a balancing of 10% people. That in 10% people, you can expect that the first stage of vibration syndrome will appear. So this model is quite popular and it is epidemiologically validated. But in case of neurological symptoms, this is absolutely conflicting. Means we do not have a model so far. We have taken up this job in Udaipur also, and also in other countries we are trying to work out what is the relation between the hand-on exposure and the neurological symptoms. The symptoms that we are examining are the changes in grip strength in kg, the pinch strength in kg, and of course the nerve conduction velocity. We are using EMG machine and the nerve conduction velocity instrument for finding out what is the change in the nerve conduction velocity. So we are expecting a relationship to build up between the exposure, vibration exposure, and the variations in the grip strength, pinch strength, and the NCV. These three. The international standards say, the European Union directive says the exposure action value is 2.5 and exposure limiting value is 5.0. It's something like DGMS guideline in noise 85 and 90. So in vibration we have 2.5 and 5.0. Of course this is for hand-on vibration only. And of course this one, American Conference of Government Industrial Hygienists, they also have the similar 2.5 and 5.0. These are the values. In the standard, you don't get a clear-cut directive. ISO standard does not give you a clear-cut directive. These are certain study results which we will not discuss. Now we are going to whole body vibration exposure. Whole body vibration is sitting posture, where you can see this is the X direction, this is Y, and this is Z. So we put accelerometer on the seat of the equipment and measure the vibration, and then we calculate the risk there. We have two major standards. One is 2631 part 1 and the other is 2631 part 5. Part 1 does not give importance on the age of the person, years of exposure, or age at which the exposure started. All those things are not given importance in part 1. But part 1 of the standard has been most extensively used. And our primary studies which we started in NIMs also use this framework, where you have in the x-axis the time of exposure in a day, and here is the acceleration in meter per second square. If you are falling in this zone, you are safe, and if you are falling here, you are likely to have these things, and here it is sure, means the risk is very high. This is an empirical equation, and we have used a nomogram for estimating the risk. And the risk and the lower limits in terms of A8 is 0.45 and the upper limit is 0.90. Highest value is 0.90. Remember that DGMS said that it has to be carried out as per ISO standards. ISO standards are quite stringent, very, very stringent. Means 0.45 and 0.9 is very low value. That if the industry wants to maintain this, it will be practically impossible. But I have given, of course, in 2014 also I have suggested something which I will again discuss today. Now the epidemiological part, the most famous or rather well-known thing is low back pain, which I don't want to discuss in front of because you are more knowledgeable about this. But the more common cases where it is very difficult to distinguish between the vibration exposure and the other problems, because there are so many compounding factors like the poor posture, sedentary lifestyle, repetitive strain, lifting heavy loads, and whole body vibration, which we are discussing. Then aging and degenerative conditions like herniated disc or arthritis. These are all compounding. It's very difficult to distinguish these things unless we have specific statistics to find out the relationship between these. This is only to say that the low back pain incidences or prevalence is increasing. Expected in 2050 it will take in a higher position compared to what we have today. This is from the global burden of disease. Now, so what are the common reasons for this problem? Like say we have bad haul roads. Also during loading, if you are loading in big boulders, so there will be huge jumping. So that will cause vibration. And not only that, there is a tendency of managing things like when the seat is there, creating problems, so you put some welding and then stop it there. Of course, the new dumpers which are coming nowadays are having certain pneumatic cushioning, pneumatic suspension that is working better, but there are certain issues related to that. Now, how the seat of a vehicle is performing, how do you know that? Is the seat good for vibration or bad for vibration? That we want to know. So what we have done, that we have put two sensors at two places. One in the cabin floor, which is attached here, this one small sensor, and the other is on the seat. So the vibration that we receive here, divided by the vibration originally produced in the cabin, gives you an index. If it is 100%, that means the seat has got no function. If it is 0.85, that means 15% attenuation is already there. But if it is more than 1, it can be. If it is more than 1, that means the seat is resonating. The seat frequency, natural frequency, is coinciding with the system frequency or the vibration excitation frequency. So in that case, we need to adjust the seat in such a way that the natural frequency changes and does not coincide with the stimulus frequency. These are the results of my PhD scholars, where we have analyzed the vibration in different directions on the different seats. The problem with the model that we have just now seen is that it does not take into account the age of the person or BMI, and of course, it does not take into account at what age the exposure started. All these things are not accounted for. So the ISO has again published part 5, where all these factors which were missing in the part 1 is now included. It is called part 5 2004, and it is also well formulated because the actual the vertebral pieces that has been taken out, and in lab it was tested for the material strength. So all numerical modeling parameters were included, and a new standard has come up, where the risk of injury, lumbar injury model, which is used for risk evaluation. So what you can see from here, that there is something called 0.8 RA value and 1.2 RA value. So if you are between this, you are having moderate. If you are less than 0.8, you have no risk practically. and if it is 1.2 or more, then you have high risk. We have tested this model in field conditions with 304 dumper operators and dumpers in central India, and we have seen that this model is underestimating the risk. The epidemiological values are much higher than what the model is saying. So what is suggested that these values should be adjusted, and in 2 other countries also they have suggested same thing. We are additionally suggesting that this cannot be a single value for all the countries. There are ethnic variations, so the values which are suitable for the Americans or Canadians or Australians cannot be suitable for Indians, and Indians does not mean a single type of person. It is as good as the whole world. So the mining population requires a huge number of subjects to be studied to come to a conclusion, and we should not follow a standard that is given by the European or the Americans so directly. We must study and then find out our own standards. So I just take 2 minutes more, 2-3 minutes more. Recommendations of the 10th conference where the DGMS said that it should be as per ISO standards. As I said, the ISO standards are very, very strict, only 0.45 and 0.9. But since long about 20 years, the European Union and the ACGIs, they have a little liberal standards, where limits. From where I talked to the people who were in the committee, technical committee of framing the ISO standards, and they said this was basically decided in consultation with the industry and the occupational health specialists, trade union, academicians. So we decided that this should be relaxed to begin with, because if it is too strong, then it's very difficult to follow. Other than that, what we suggest that a specific long-term cohort study should be done. So I recommend here, it's a kind of recommendation based on the studies that we conducted, that let us adopt some lenient norms instead of ISO standard, and we can examine ACGIs or European Union standards and try to find out what should be suitable in all these things. So should be in consultation with DGMS, academics, industry and trade unions all together, sit down and find out this standard. What should we follow? And the idea is, it is better to understand the multifactorial origin of vibration and look at the problems of solving the problems of the hull roads, problems of the seats, all those things, instead of trying to find out the highly mathematical things which does not always comply with the practical world observations. We must include occupational health in mining curriculum. This is because I am teaching here in IIT Kharagpur and it is not there. Even people are dispensing with safety engineering. It is not in the subject. Safety means legislation. Nobody wants to study, nobody wants to teach this legislation part. So that maybe for some reference should be there. But occupational health and safety engineering must be made compulsory in the mining country. Specific clinical tests to be included, because in periodical medical examination there is vibration related syndromes. So what I suggest, a specific test should be mentioned in the list. That these should be tested and reported. Whether it is related to vibration, that the medical doctors will decide. But this should be clearly said that what clinical test you are prescribing for finding out the vibration symptoms. And as I said, large-scale cohort studies. Our studies are either 300 or 500, but considering the huge population in Indian mines, we should go for large-scale cohort studies and interventions in the field of human vibration in mines. Thank you very much.
Thank you, Dr. Mandal. Simplifying a topic is highly complex. And I must congratulate you for this particular talk. With the increasing mechanization in the mines and all major industry, vibrations have become a very important topic nowadays. And DGMS is already underway to formulate some of the standards, which were originally recommended by the European Conference long time back. But considering what research outcome has come out of the NIH study in vibration and Dr. Mandal and group, this probably will form the new standards, basis for the new standards for Indian. And as Dr. Mandal has said, see, what is applicable in Kashmir is not applicable in Kerala. What is applicable in Rajasthan cannot be applicable in Myanmar. Because our population is so varied, technically we are so much varied that every institution will have a different kind of standard. So thank you, Dr. Mandal. I don't really, because if I ask questions, it will be questioning whether I asked. You asked many questions. You have already asked too many questions earlier. So I would keep the house open, this particular session open to questions by the house if anyone has any questions. Yes, sir. Please.
Sir, you have taken that heavy, there is one more truckload and showers and truckload, etc. Heavy vacuum moving machine. So they are having all the vibration. You are taken as a 10th class level algebra, etc., which is very difficult to us to understand. But these data, these values, who will be given to us?
Means the measurement values.
Measurements values are regular.
You can get the human vibration meters, which are easily available now in India, and you can get the training from us. I personally train how to use that, because there are so many things which I have not shown. That will take some 1 or 2 hours, minimum things. So how to set the machines, how to take the readings, how to process in the computer, that I can tell you.
So, okay, that mission is
even noise induced meter.
Yes.
We just know how to on and off and how to see that how to see the readings. We don't know the much about the internal calculation. Same the vibration. These are for the understandings. But actually we are not going to sit and calculate the data. We will just open the machine, take the training from this institute, and we will know how to read the readings. And already in our OSI standards we have included the permissible limits taken from these institutes only, and we have to follow those standards. That's all. We did not go into being a doctor. We did not go into the nitty-gritty how we are reaching the data. That those figures will be given by the vibrant measuring equipment directly to us, and those training how to operate those technical context.
Standards that the equipment producing units.
Yes.
Sir, what about this test that you can detect the vibration? Because Country Safety Conference recommendations, there are vibration.
No, that has been done by the respective companies and some with the help of this technical institutions.
There are many companies who have already procured this instruments.
Sir, is there any online course for the training?
Online course is not provided, but and it's not recommended also. It is better that we understand things in a classroom and we practice it there in the field. So if you attend the courses in IIT Kharagpur or anywhere where it is done, then you can first learn the theoretical things, and then we have our cars and motorcycle, and then we can have how to measure, how to interpret. That can be easily taught there. No issue. Online courses are there, but then you won't be able to ask questions like this.
What is the ratio of online by your?
Yeah, and then there are so many settings in the machines. Why it is so? How to follow the international standards is very difficult. So unless we follow, as Dr. Sakura was repeatedly telling, if you don't study the rules, regulation, acts, and ISO standards, there are many questions are answered there itself. There itself.
You have to go through the literatures and go through the processes.
And if you just search my name in the researchgate.net, you get a good number of publications on this subject. So you can study all of them. If you can.
One more question, please. Yes, sir. Introduce yourself, Karthik.
Sir, I am Dr. Karthik from Collider Limited, sir. We are having a vast number of dumper operators and operators in our company. So, if we want to do the survey on these whole body and hand-on vibration studies, so can doctors be trained in this, and doctors can do this study?
Doctors can, it will be difficult for him to understand the
Yes.
The mathematical part,
Yes.
calculation,
Can,
but it's not very difficult.
Who is the person can use?
So you can simply write dbcontrol@gmail.com. Write anything on vibration, I will respond to you.
Yes, sir.
I will there.
And who can be tried in doing this studies?
Especially at least
Safety officers.
BTech on engineering background, that will be better. And when you do this analysis and interpretation,
yes,
you should have one doctor with you, so that whatever the medical terms that I am working with Ames Bhubaneswar,
yes,
is one doctor who is collaborating with me. So the medical terms, terminology, whatever, and the way I am explaining things should not be something which is wrong. So we make a team. Occupational health, the hygienist and the health people should work together.
So you from your institute or
I am yes.
Thank you.
Actually, we have to understand one thing. Industrial hygiene is an integral part of the occupational health. Okay. But industrial hygiene part, there are so many things that they are just totally mathematical and engineering oriented. Those parts, we cannot go into detail. We have to take help from the engineering people or mathematical people or statistical people. Collaborating with them only we can get into the hygiene part. Other than that, the medical part and health part is okay, it's totally our domain. But hygiene part we have to take from them, we have to take from the research institute and collaborate with them. For example, vibration study is a part of the industrial hygiene. This is ACGIH and all, they have done the study long back. We are doing now. So they are able to collaborate with them, all these technical institutions. And after getting the hygiene monitoring part and all these things done, then health analysis we can do ourselves. This is what everybody is. Any questions? Any more questions? So I think we'll conclude this wonderful presentation by Dr. Mandal. As Dr. Shishodi has said, complicated things simplified to best of our consumption.
I tried. That's my
yes, we tried. Now we'll do the honor as a mark of recognition to his expertise and sharing with us.
Thank you, Dr. Sarkar and DGMS for giving me the opportunity to speak on this national workshop. It gave me a chance to meet with so many, good delegates from esteemed mining companies and different organizations, and especially a chance meeting with two of my previous mentors, Dr. R. Theory and Dr. P.K. Shishodia. Thank you very much.
It's a relatively a new topic for the industrial hygienist also. So not many people are experts in the vibration measurement. So I would suggest that we take the help of Dr. Mandal, who has been working on this in almost for more than 15 years. So if the Coal India wants any surveys to be conducted during the time, it also get into surveys to various dumpers and other things. We are not present with the data here, but it's a substantial risk. The government risk is very high using the vibration. Most of the dumpers is in fact at the top of the list. After 2 bulldozers, dumpers are the next one.
Thank you so much, Dr. Mandal. Now we will come to the second paper of this presentation. None other than another expert in his own field, Dr. Rajnarayan R. Tiwari. Actually, if I start reading out his qualifications, it will be more than the introductions. So even then it is 2 lines. His qualification takes 2 lines. He is MBBS, MD with Community Medicine, PhD, Masters in Health Administration, MA Sociology, MA Economics, AFIH, FIMS, and FAMS. That means he has been qualified in all fields of life across medicine, public health, hospital administration, economics, and sociology. Anyway, it is a great opportunity to learn from him. He is Director and Scientist G, ICMR, National Institute of Research in Environmental Health, Bhopal. He is Director of Additional Charge of ICMR, National Institute of Research in Tribal Health, Udaipur, and he is the former director of ICMR, National Institute of Occupational Health, Ahmedabad. His topic is study of chronic manganese toxicity in MSD. Please listen to me.
Good evening. I come back from vibration mode to voice mode.
Dr. Tiwari, just 1 minute before we start. Friends, Dr. Mandal presented a topic which was new. He is going to talk about a topic which is almost forgotten over the years. In fact, just to introduce the topic, in 1956, one of the managers of the mine in Jadol office walked into the DGMS office and said some of the workers are becoming violent and psychologically deranged. They were also having the problem with incoordination, and they were crying in their, So based on that basis, the DGMS office instituted an inquiry in at 1964 and 1961 and identified 4 cases of manganese poisoning, and we have not identified a single case afterwards. Because that time the dry drilling was going on in these mines, that's why manganese mines were concerned. And you see, I think this is a forgotten topic because even the DGM has forgotten the topic. So I suppose once Dr. Tiwari starts talking, some of us will get enlightened and will bring back because we have tried in while to look into some of the aspects, but unfortunately we have not lost that. So, Dr. Tiwari, the stage is for you.
So greetings from one city of Lake Bhopal to another city of Lake Udaipur to all of you. So as mentioned by Dr. Sisodia that this is a topic which is forgotten, but then when you see the list of notifiable and compensable disease under the mindset, it is very well there. Now we all know the usefulness of manganese for our normal physiology. So it is a very essential trace element belonging to the transitional group of elements in the periodic table with all these numbers and masses. The important thing is that it appears in varied oxidation state, and +2, +3, these are very critical when we talk about the ill effect of manganese in the human body. The compounds, inorganic compounds are there, but then inorganic compounds usually pose occupational health problem, but it is this new use that in terms of organic compound that has changed the paradigm from occupational setup to the environmental setup. Because the 2 top organic compounds, they are used as pesticides, and the third one is used and was proposed to be used in many places as an octane enhancer in place of tetraethyl lead when we de-leaded petrol in 2000. So that is another source which can give rise to occupational environmental exposure. Why this is important? Because it is one mineral where we have very good standing when we compare globally. So we have very high manganese properties in our country, and so the use is wide and source is there, so there are chances that the manganese mining will be as rampant as coal mining where we rely on fossil fuel. And these are the states. Madhya Pradesh is the chief contributor, and I got an opportunity to work in one of the best underground manganese mines at Balaghat. So I will be coming to that in the later part of my deliberation. So as I said, occupational exposures are there, mining being one, then burning of coal being another, and then lot of processing and reprocessing. Battery industry being the latest consumer of manganese which is being mined. So a lot of processing and reprocessing will result into occupational exposure. In addition to that, there are a number of environmental exposure also. So it is not only related to the mine, but it is for the entire society. So natural ores, waste disposal, or from different type of pollution, which I have already told. We all know it is a wonder element which is there largely used for the alloy industry, whether mixed with iron, whether mixed with silica, to increase the strength, as well as the property of that particular alloy. In addition to that, as I said, the dry cell batteries are new consumer of manganese. A lot of manganese is used as an oxidizing agent and in fertilizer, animal feed, pharmaceuticals, and all other industries. A brief history about MMT. In fact, when de-headed petrol was popular across the globe, then to increase the fuel efficiency, one corporation, Heath corporation in Canada, they proposed to add MMT into the gasoline to increase the efficiency of per unit of petrol. At the same time, EPA sued that company because they know that the manganese has long-term chronic disability effects. But then unfortunately EPA lost that case, and then that company was allowed to add MMT. And both the sides, they have given their representation. While Heath corporation said that when we use MMT in gasoline and when we measure the concentration in the air, nowhere from parking to roads to riverside, the concentration crosses the permissible level which is prevalent at that time, either in Canada or in US. So that was the plea, whereas EPA said because when we use MMT gasoline, it affects the vital part of the vehicle, so it affects the vehicle health. This damage to the vehicle will result into increased emission of NOx, SOx, and hydrocarbon. And these all three are known to cause human health effect. So that was their plea, but because of absence of any evidence against MMT, the Heath corporation was allowed to use that. So at the same time, because there was lack of evidence, so EPA thought that we should conduct a study to find out what is the scenario. And because MMT was not being used at that time, so there could not be any scenario, but that was the chronic low dose scenario, and that happens in underground mines. And so they commissioned that study to NIL. At that time I was a part of NIL. So it was commissioned to NIL to study the effect of manganese in underground mines. So we did that study maybe 15 years back. So these are absorption, distribution, metabolism, and elimination of the element, but the thing which is to be seen is the mean biological half-life. It is 4 days for the fast phase and 39 days for the slow phase. And because of this, many times when we measure the blood manganese level, it does not correlate with the clinical symptoms. So these are the physiological functions. A lot of physiological functions are there because it is a component of the powerhouse of a cell, that is mitochondria, and we know how important that is. Yes, Dr. Sisodia was saying, John Cooper was first to find out that this element could also be toxic, so he reported in 1837. And at that time, there was a new technology where manganese was used, and that resulted into increased exposure, and that was resulting into neurological problem. And 120 years later, in 1956, as Dr. Sisodia mentioned, in the same Ballarat mine, Mr. Sen Gupta was junior administrator. He observed that few of the miners, they had some mental problem, and then he referred those patients to Dr. Niyogi, who was the civil surgeon at that time, to get an unfit certificate. So when he examined and he published that then acute type of manganese is usually seen when high concentration of dust or fumes are emerged, and mainly it results into more of a manganese pneumonia or the metal fever type scenario rather than the chronic neurological problem. And with all the safety measures at place, nowadays the acute phenomena is a very rare happening, and there is accidental emergence of huge concentration of fume or dust. So chronic problem is there, and so if we follow these work over a period of time, we will encounter this chronic toxicity. The initial phase of chronic toxicity is very subjective or non-specific with all symptoms. It is nothing related to manganese toxicity per se, but the early stage and established chronic poisoning results into chronic neurological symptoms. And these symptoms, if you see, these mimic the age-related condition that is called as Parkinson's disease. But then there are certain distinguishing features between Parkinsonism and the manganese-related neurotoxicity. Largely, the manifestations are because the extrapyramidal system, locus calidus and substantia nigra, these are the two areas where manganese gets deposited, and then it results into the neurological manifestation. In the established chronic phase, along with the motor changes, there will also be established psychological symptoms which we usually see in the prodromal phase, like somnolence or hyposexuality or insomnia or unmotivated laughter or weeping, so change of mood. So these are initially not a regular feature, but then when the person lands up into the established phase, these become the regular feature of the condition. I will not go into the detail because these are all technical things, how manganese results into neurotoxicity. It affects the neuron, it affects the astrocytes, it affects the microglia, it affects the glucose metabolism, and there are n number of theories for the toxicity. Exact cause and effect relationship and the mechanism through which that is happening is not clear, but then every investigator, when they try to look into it with their perspective, they pose a different set of hypotheses for this causation. But then gait and stability, because we all know the extrapyramidal system is responsible for the stability of a human being. So when that is affected, that results into this cock gait where the person used to walk with the metatarsophalangeal joints. So this is the gait which is there, and the stability is very friable. So walking backwards or half down or climbing up or standing feet together, this makes person unstable and he is unable to stand for a longer time. Also, the established case will result into micrographia. So the letters become small and small, and then along with that there is a tremor, intentional tremor. So that will result into vibration. So this is another thing which will be seen in the established case. IRRST, they have developed with the group of experts, they have developed this criteria where clinically possible, clinical probable and clinically definite criteria for diagnosing chronic manganese toxicity were laid down, and because earlier days it was largely on the clinical acumen of the doctor, but now we have good diagnostic tools to find out the manganese deposition as well as the abnormality caused by yield. So there are number of cases or number of conditions which will mimic chronic manganese toxicity, but then if we take occupational history very meticulously, it will definitely help in distinguishing the condition of chronic manganese toxicity from these conditions. So these are some of the features which will distinguish PD from manganese toxicity, and if you see the unfortunate part is that manganism does not respond to L-DOPA. So that is more problematic. For Parkinsonism, at least we have L-DOPA to treat some of the symptoms, but for manganese, apart from prevention, we cannot do anything. And what is happening in the tremor which is happening in manganese and Parkinsonism disease, these are the paths where the inhibitory part is lost in manganism, and so whenever the person is asked to do some activity, the tremors appear. Whereas in Parkinsonism, the excitatory part which is lost. So this is the difference between, if you see pathogenesis, this is the difference between the two. So when we talk about treatment and management, removal of the worker from the further exposure is the best thing, and then we have therapies, chelation therapies for acute toxicity, and then all other therapies which have been tried, but nothing is completely successful as far as chronic manganese toxicity is concerned. Levodopa, as I said, poor response and progression of the disease even after suggestion. Iron supplementation in those who have initially received chelation therapy for the acute poisoning has been found to be responding. Then some supportive treatment like vitamin E, glutathione, acetylcysteine, or some plant extract have been found of use to some extent. And then the newer therapies like taurine and the rasagiline, these are also being tried. Now these are the guidelines. Now you remember this, the OSHA and ACTI, they give the guideline 5 mg per meter cube for the workplace. And so under this background which I have already told, we conducted this study, and initially we took C48 manganese minus, and then out of that, those who had raised blood level, those who have symptoms, we sorted out, or we subsampled 90 people whom we have subjected to all these investigations like CNS examination, magnetic resonance imaging. When we did that study, during that time there were no MRI with 1.5 Tesla. So we searched Nagpur and all places, but we could not find any MRI with 1.5 Tesla. Incidentally, at that time, and Ahmedabad Apollo Hospital was opened, and it came up with 1.5 Tesla machine. So we brought all those 90 patients from Balaghat to Ahmedabad and get their MRI done. So this was the levels which we found in the mine, and that is why I initially said it is one of the beautiful underground mines which is present in country. Now you see the levels. 5 mg per meter cube is the level which is suggested by OSHA and CTIA, and here we found levels in microgram. So such was the environmental condition. So, and obviously when there is the environment, if the work environment, if the etiological agent is not there, obviously it is not going to reflect into the health of the people. But then this was a very short duration measurement. So we conducted the health examination also, and we subjected them to a battery of neurobehavioral tests. We could not find significant difference between those who are having low low manganese level and high manganese level, but then some indications were given, and as I said, the biological half-life plays a role, because within 4 days of the exposure, around 80% of the manganese which is entering into the blood is excreted out. And so many times, if you want to see the mean group level of manganese, it may correlate with some of the signs and symptoms, but when you go for the individual correlation, you fail. And it is because of the this excretion of the absorbed manganese in the blood. When we did the MRI of these people, we found that 86% of these miners have shown hyperintensity in the globus pallidus and 72% in substantia nigra. And these were the two areas which is largely affected. And the hypersensitivity was because of the deposition of manganese in those areas. Same way, we also tried to analyze the blood manganese level in those where the hyperintensity was there and those where normal intensity was there. Obviously, the hyperintensity group had higher blood manganese level, which says that whatever is there crosses blood-brain barrier and then get deposited in those areas. For the neurobehavioral test also, the hyperintensity group has shown sub-abnormal results, though it was not statistically significant, but then it gives us indication that these need to be continuously supervised. And these are other findings. 17% they had neurological symptoms, 34% had psychological symptoms, and then 6% tremors, 19% had clinical pallor, 74.4% had blood manganese level more than 2 microgram. We also tried other hormones like adrenaline and dopamine, and these were found to be higher than the normal prescribed values. So this is another change which happens when the person is chronically intoxicated by manganese. We also tried to find out this biomarker like pallidal index, where the intensity in the frontal lobe, which is considered as the control area, and the globus pallidus, which is considered as the affected area, the ratio of 2, ideally it should be less than 110. But then we found around 25.5% showing pallidal index more than 110. I think this is also the takeaways is that this is a toxicity which is silently appearing, and so it requires close watch among those 5% they are showing pallidal index more than 110. Number of tools nowadays, easy tools like takeaways is that this is a toxicity which is silently appearing, and so it requires close watch among those 5% showing pallidal index more than 110. Number of psychological changes nowadays, easy tools like takeaways is that this is a toxicity which is silently appearing, and so it requires psychological
Now we will start
question from
for
with this fibrosis restriction, drug penetrations known, tuberculosis, mycobacteria. Recurrent pneumothorax is one of the challenges as per the disease concern, severity of the disease concern, alveolar blockage. The systemic challenges is a smaller units mainly in the alveoli there is a smaller units that is not compliance with the regulations, unauthorized, unorganized sectors, and they are not cooperating with the other doctors or other neglect the rehabilitations and other thing lack of the standardization in the diagnostic protocol. These are the challenges. As far as the silicosis is concerned, that is the main and getting shortage of the time. This is my workplace, Regional Occupational Disease Center, which is established by the ESIC under the Government of India and Ministry of Labour. This is the occupational disease ward I have established at the ESIC, a special occupational ward like the other ward, TB ward or medicine ward or surgery ward. There is a 20-bedded ward where I am doing the screening, continuous screening with of the factory workers or of different factory. The factory, one of the pioneer program that is one of the pioneer program that is run from the ESIC Alwar in the under the ministry is the factory health adoption program. I have adopted till date 37 factory, and we are doing the screening of the workers, and till date I have done about 7,000 workers in the different factory for the occupational health. And I have also participated in the Silicosis screening at the Dausa, where I just suspected that time total 22 cases. And these are the other part of the factory health adoption program which I am doing along with our team. This is the ESIC Alva, and thank you.
I have 3 comments to offer. There are no questions from my side. One is that we rarely see silicosis in marble mines. The reason is very simple, because the percentage of silica in marble stone is very less. Number 2 is the presence of just eggshell calcification does not indicate silicosis. So, because many of the doctors tend to get confused, presence of eggshell calcification by itself does not mean silicosis for the purpose of diagnosis. It just means that the person has been exposed to silica. And third is, sorry to say that your topic and the presentation do not match with each other. So I would suggest that next time when you make a presentation, topic should be relevant to the text.
Sir, normally I was advised that you have to cover the pathogenesis and
Thank you for
part
doing
and
it.
other
But
doctors from the mines.
silicosis is not the silicosis in marble. That is what I would so thank you for the presentation. Thank you.
Any questions from anybody?
Otherwise, we go to the last topic of this session as well as program. One topic was left out, that is Dr. Mandari. Before that, we will thank Dr. Suman and we honor him with a piece of memento for sharing his knowledge and information with us. So now the last paper of the session, that is by Dr. S.K. Bhandari. Dr. Bhandari is MBBS, certified in occupational health and ILO classification of chest radiograph. He worked in the Rajasthan Medical and Health Services for more than 35 years and currently head of medical services in JK Latin Cement, Shiroi, Rajasthan, with a total experience of 39 years in the field of medical and health.
Dr. Escort, please.
थैंक यू। मैं आपका दिन का समय खराब कर रहा हूँ। अभी आपको काफी परेशान भी होना पड़ा। कृपया आखिरी एक शॉट मेरा भी देखा जाए। मैं सभी को अतिथियों को प्रणाम करता हूँ और स्पेशली जो डायस पे मंडेकर साहब और हमारे सीनियर ऑफिसर वह सागर जी बैठे हैं, कृपया और मेरे अजीत सरकार साहब ने जो ये आयोजन किया है, आई एम वेरी थैंकफुल टू दैम। और मेरी इस छोटी सी जर्नी में मेरे काफ़ी सहयोगी रहे हैं। उसमें एक यहाँ बैठे हैं हमारे जेपी लक्ष्मी के माइंस हेड सोलंकी जी, थैंकफुल टू। मैं करंट सिनेरियो पे डायरेक्ट आ जाता हूँ और मेरा थोड़ा सा ब्रीफ नहीं किया 39 ईयर का, लेकिन माइंस में मैं अभी बच्चा हूँ, इस प्रोफेशन में मैं अभी बच्चा हूँ, तो कृपया मेरी जो भी त्रुटियाँ हों वो आप माफ करा। ऑक्यूपेशनल हेल्थ सर्विसेज जो आपने 4 डिवाइड किया है, करंट सिनेरियो, चैलेंजेस एंड वे फॉरवर्ड, उसमें मैंने एक और ऐड किया है रोल ऑफ मेडिकल ऑफिसर, DGMS, माइंस मैनेजर, माइंस ओनर, एजेंट, ह्यूमन, फैमिली एंड सोसाइटी। ये सब चीजें ये शो करती है। मैं आपको थ्योरेटिकल नहीं पढ़ाऊंगा क्योंकि ये सारे आप पढ़ चुके हैं। मैं आपको प्रैक्टिकल एस्पेक्ट पे ले जाता हूँ। आप इमेजिन करिए जो वर्कर काम कर रहा हूँ वहाँ पे माइंस में, वो कोई न कोई इंसान है, किसी का वो पिता है, वो किसी का भाई है, किसी का पति है और किसी का दोस्त भी है। और अगर उसको कोई इंजरी होती है, ऑक्यूपेशनल हेल्थ सर्विसेज का मेन मकसद वही आता है, तो उसके लिए जिम्मेदार आप हम सभी हैं। ये नहीं कि वो अगर प्रोफेशन में आया है तो वो बेचारा वो इंजरी झेलेगा। तो कृपया करके आप और हमारी जो बहुत बड़ी जिम्मेदारी बन जाती है कि हम क्या कर रहे हैं और हमारा ये जो रूल्स रेगुलेशन है ये कहाँ तक उसको सपोर्ट करता है। फर्स्ट वी आर इन इंडिया, अपने इंडिया में लार्जेस्ट माइंस हैं ऑल ओवर वर्ल्ड और उसमें मिलियंस ऑफ लेबर काम कर रहे हैं। क्या अपन इतने अवेयर हैं, क्या अपन इतने सेंसिटिव हैं कि उसको अगर पीपी इक्विपमेंट भी अगर टाइम पे मिल जाए तो क्या ये अपना फर्ज नहीं बनता? क्या उसको फैमिली में अगर मान लो कोई इंजरी हो जाती है तो उसको सपोर्ट नहीं मिलना चाहिए? क्या वो 100 साल जीने का हकदार नहीं है? क्या वो 30-35 में ही सिलिकोसिस या न्यूमोकोनियोसिस या कोई भी बीमारी से ग्रसित होगी और उसको अपन कहते हैं साहब डायग्नोज नहीं हुआ? आप यकीनन मानिए अपन सब लड़के बैठे हैं यहाँ पे, जितने भी केसेस होते हैं तो उसको शिफ्ट कर दिया जाता है। आज न्यूमोकोनियोसिस हो गया, किसी को टीबी हो गई, किसी को कोई प्रॉब्लम हो गई, तो अपन उसका जॉब चेंज कर देते हैं, वहीं से उठा के उसको और नहीं लगा दिया। और कुछ हुआ ज्यादा माइल्ड मॉडरेट सीवियर, उस स्टेज पे लाते लाते अपन क्या करते हैं, माइल्ड है तो उसको बाहर निकाल दिया, मॉडरेट हुआ तो उसको घर में वो खुद ही घर चला जाता है, देख भैया तेरे से काम नहीं हो रहा तो चला। तो कृपया करके उन चीजों को, और स्पेशली काम होता है कोल माइंस, आपके स्टोन माइंस और जो अपने सीमेंट या जो भी डस्ट से रिलेटेड चीजें हैं वहां पे होता है। और नहीं कहते हैं कि सर हमें तो कोई न्यूमोकोनियोसिस या सिलिकोसिस का केस मिलता ही नहीं। वो फर्स्ट माइल्ड मॉडरेट सीवियर जो सर ने कहा कि उसको अपन फर्स्ट ईयर में क्यों नहीं डायग्नोज कर देते? तो प्री एंड रेगुलर चेकअप मस्ट बी देयर। बेसिक जो अभी लेटेस्ट करंट सिनेरियो है वो मैं आपको बता दूं कि करंट सिनेरियो में प्रैक्टिकली बात कर रहा हूँ, मैं थ्योरेटिकल बात नहीं कर रहा हूँ। आई एम नॉट ए एक्सपर्ट। माइनिंग सेक्टर वेरी रिस्की इन द पॉइंट ऑफ व्यू द irreversible diseases plus risk of accident and life in danger. रेगुलेटरी करंट सिनेरियो में मैं आपको बताऊंगा कि मैंने आपको मेरा आगे का नहीं बताया, सॉरी। यस सर, यहाँ में मैं था कुछ दोपहर की नींद में मैंने आपको इतना खींच लिया कि मैं भी भूल गया मैं नींद में हूँ या नहीं। रेगुलेटरी फ्रेमवर्क में मैं ये चाहूँगा कि जितने भी जो अपने एक्ट्स बने हैं, रूल्स बने हैं, रेगुलेशंस बने हैं, उनको अच्छी तरह फॉलो किया जाए। करंट सिनेरियो जो है वो उसमें नहीं फुलफिल हो रहा है, लेकिन इन रूल्स को काफी इग्नोर किया जाता है। नेशनल सेफ्टी कॉन्फ्रेंसेस काफी हमने की है, आईएलओ कन्वेंशन भी हुए हैं, वेरियस सर्कुलर इशू बाय डीजीएमएस इशू किए गए हैं, वो फॉलो भी हो रहे हैं। ऑक्यूपेशनल सेफ्टी हेल्थ एंड वर्किंग कंडीशंस कोड ऑफ 2020 फॉलो हो रहा है। मेडिकल फैसिलिटीज में जो रेगुलर चेकअप और जो किया जा रहा है उसको हमने काफी इम्प्रूव किया है। और फॉर डीपर हॉस्पिटल रेफरल भी हमने काफी करते हैं, लेकिन ये सब कहाँ है जहाँ की वेल ऑर्गेनाइज्ड कंपनीज है, वेल ऑर्गेनाइज्ड माइंस है, और अनऑर्गेनाइज्ड या स्मॉल माइंस में ये थोड़ा लैग बिहाइंड है। हाउएवर स्मॉल माइंस को और हमें उसको ध्यान देना होगा। नेक्स्ट, करंट सिनेरियो में हेल्थ मॉनिटरिंग इज आल्सो ए प्रॉब्लम। डीजीएमएस की गाइडलाइंस से हम इसको पूरा मैंडेट रेगुलेटरी हेल्थ चेकअप चल ही रहा है, और सर्विलेंस पार्ट भी हम काफी करते हैं, स्पेशली डस्ट, नॉइस एंड केमिकल्स के रिलेटेड। और रेगुलेटरी मेडिकल चेकअप, रेगुलर ऑक्यूपेशनल हैजार्ड्स को देखते हुए, स्पेशली फिजिकल, केमिकल, बायोलॉजिकल, मैकेनिकल, साइकोलॉजिकल, एनवायरमेंटल, सारा ये बता चुके हैं मेरे पहले के वक्ता। और प्रिवेंशन ऑफ सेफ्टी, इसमें भी थोड़ा हम अच्छा कर रहे हैं। एडमिनिस्ट्रेटिव एस्पेक्ट है, इंजीनियरिंग एस्पेक्ट है, मेडिकल और अर्बन, इसमें हमने काफी अच्छा काम किया है। डस्ट कंट्रोल में, नॉइस कंट्रोल में, और पीरियोडिकल एग्जामिनेशन में, पर्सनल प्रोटेक्टिव मेजर्स भी काफी काम ले रहे हैं, लेकिन उसमें जो लापरवाही हो रही है उसको अपन को देखना भी पड़ेगा। वॉइस प्रिवेंशन प्रोग्राम, पोस्ट एक्सीडेंटल एंड रिहैबिलिटेशन पे अपन कम ध्यान दे पा रहे हैं। और एनुअल रिव्यू भी हो रहा है, लेकिन इतना इफेक्टिव नहीं है वो। Challenges in occupation, despite of existing framework हो रहा है, लेकिन इसमें सिलिकोसिस वापस मुख्य वो बात आती है जो मेरे दोस्तों ने कहा है। सिलिकोसिस न्यूमोनिसिस पे अपन विशेष ध्यान दें। अगर आप भी इसको डायग्नोज करें और डॉक्टर्स और अपनी टीम बहुत ही सेंसिटिव होगी जब ये काम होगा। आप ये मान के चलिए कि जो भी अपने प्रिवेंशन की बात कही है, चाहे वो पानी स्प्रे की बात है, चाहे वो डस्ट में जो लेबर काम कर रहा है, उस टाइम मैंने एक नीचे स्लोगन दिया है, मैन एट वर्क 5 मिनट्स टू टॉक, हेल्प फॉर ऑल। उस आदमी को जो वहाँ पे काम कर रहा है वो एक इंसान है, आप और हमारी तरह है। कृपया उसके बारे में सोचिए कि वो वहाँ पे काम कर रहा है कितने डस्ट में, और वो कंटिन्यू करता है ईयर टू ईयर, और फिर अपन कहते हैं 5-10 साल में जाके वो डायग्नोज होता है। आपकी आंखों के सामने हो रहा है, आप उसके पास से निकलते हैं, आप बच के निकल जाते हैं। कृपया उस इंसान के बारे में सोचिए, मैन एट वर्क है वो, 5 मिनट्स टू टॉक, वो काम चालू कर रहा है, उसके पहले आप वहाँ स्प्रिंकल कर पे जो भी डस्ट है उसको मास्क वगैरह पहना दीजिए। पूरा उसका काम जो है वो सुपरवाइजर को करना चाहिए, हेल्थ फॉर ऑल, और उसको अपनी हेल्थ के लिए अवेयर होना बहुत जरूरी है। उसके लिए अपन जिम्मेदार है। ये संविधान उसको कहता है हेल्थ फॉर ऑल, लेकिन आप और हम थोड़ी सी लापरवाही कर रहे हैं इसमें। इसको भी देखा जाए जो अपना चैलेंज है। इनएडिक्वेट हेल्थ सर्विलेंस, इसके बारे में मैं आपको बताऊंगा कि ये अंडरस्टूड है कि इनएडिक्वेट हेल्थ सर्विलेंस तो अपन कर ही हैं, जिसमें हेल्थ हाइजीन, न्यूट्रिशन, फिजिकल वेलबींग वगैरह का ज़्यादा ध्यान नहीं दिया जा रहा है। अंडर रिपोर्टिंग भी हो रही है केसेस, और उससे डायग्नोसिस प्रॉपर नहीं हो पाता है और टाइमली उसको ट्रीटमेंट नहीं मिल पाता। तो वापस अपन को वही दिमाग में रखना है, मैंने कहा है 5 मिनट्स टू टॉक और हेल्थ फॉर ऑल, उसके बारे में अपन को सोचना चाहिए। इसी के आगे थोड़ा चैलेंज ये भी रहता है, अपने लिमिटेड रिसोर्सेज है और स्मॉल इंडस्ट्री में तो या माइंस में तो आप जानते हैं कि वहाँ तो वाकई में बहुत ही परेशानी है क्योंकि इतना मिलता नहीं। लेकिन जो मेरे दोस्तों ने कहा कि उसको अडेप्ट कर दिया जाए, ये बहुत अच्छा सॉल्यूशन है। जो बड़ी कंपनी है वो उसको अडेप्ट कर ले, आसपास की 4-6 कंपनियों को अडेप्ट करके उनको स्ट्रेंथन करें, टेक्निकली हो, मेडिकली हो, जो कुछ भी अपन कर सकते हैं वो DGMS से अच्छा सपोर्ट मिल जाए तो ये काम हो सकता है। मेंटल हेल्थ इश्यूज और स्ट्रेस, रेगुलेटरी फ्रेमवर्क, वे फॉरवर्ड में मैं स्पेशली कहूँगा स्ट्रेंथन टू मेडिकल सर्विलेंस को बढ़ावा दिया जाए और जो भी अच्छा कर रहा है उसको अप्रिशिएट किया जाए और जो खराब कर रहा है उसको रोका जाए। ये मेन चीज होती है। तो अप्रिशिएशन मस्ट बी देयर। एनहांसिंग डस्ट कंट्रोल, मेन चीज वही आती है। डस्ट कंट्रोल को एनहांस करने के लिए जो भी अपने सुपरवाइजर और जो माइंस इंचार्जेस हैं वो विशेष ध्यान दें और फोकस टू मेंटल हेल्थ। उसके स्ट्रेस और उसकी फैमिली का डिस्टर्बेंस वगैरह ये आप और हमको देखना पड़ेगा। ट्रेनिंग होनी चाहिए मेडिकल स्टाफ की और पूरे नर्सिंग और एक्सरे वगैरह की, और हमारे जो भी वर्किंग पर्सन है स्पेशली फर्स्ट एडर्स उनकी भी, और इम्प्रूव द रेगुलेटरी एनफोर्समेंट। हेल्थ केयर लाइन एंड रिमोट एरियाज में जो इंडस्ट्री माइंस हैं उनका भी विशेष ध्यान रखा जाए और उनको सपोर्ट किया जाए, और स्पेशली वहाँ पे जो गवर्नमेंट बॉडीज हैं और जो हेल्थ केयर इंस्टीट्यूट है वो भी उनको हेल्प करें। पब्लिक पार्टिसिपेशन भी इसमें अपन कर सकते हैं और प्रमोशन से माइनिंग प्रैक्टिसेस को और एनहांस किया जाए। ये मेरा एक स्लोगन और है यहाँ पे कि 5 सेफ्टी गार्ड्स। इस मजदूर को सेव करने के लिए हमारे सबसे पहले माइंस की जितने भी मैनेजमेंट है वो उसका पूरा ध्यान रखे उसके सेफ गार्ड के लिए। उसके बाद में उसकी फैमिली और उसके नियर जो भी है वो उसका ध्यान रखे, उसके खाने पीने का, और उसके बाद में मेडिकल ऑफिसर और मेडिकल टीम पूरा चेकअप और ट्रीटमेंट पार्ट का ध्यान रखें, और एडिक्शन कोई भी नशा पता नहीं करे इसके बारे में उसको चेक करें। और लास्ट बट नॉट लीस्ट हमारा गवर्नमेंट एंड DGMS पूरा इसका ख्याल रखें। देन role of our staff and all these again repeated. Thank you all.
Thank you, Dr. Bhandari, for sharing your thoughts on mandatory 5 national thoughts on health for us. Are there any questions? Because I don't have any questions. Are there any questions, Dr. Bhandari? Okay, if there are no questions, then we can close this session. Thank you, Dr. Bhandari.
Thank you, sir.
Thank you, Dr. Shishodia. And on a matter, in recognition to his expertise and knowledge sharing with us, we will honor Dr. Bhandari with a piece of memento by the chairperson, Dr. Shishodia.
to an end of our day-long scientific session. A lot of things are left here. We will break here for tea, and there is a recommendation committee constituted with Dr. P.K. Shishodia, Dr. Arar Tiwari, Dr. Suman, Dr. B.B. Mandal, and Dr. Devashish Piyoni. They will join with me and my colleague, Mr. I.N. Satyanarayana, in the recommendation to finalize the recommendation of the workshop. Dr. I.N. Dr. I.N. मेरा नाम कैसा डॉक्टर नहीं लगता recommendation committee request to join me. Others can go and have tea and come within 10 minutes.
Soon we are going to start validation function in 5 to 10 minutes. So kindly be with us.
Once again, warm good evening to all of you. So, we are at the closure of this day-long workshop on occupational health. So, to begin with this workshop, I request Shri R.T. Mandekar sir, DDG Northwest Zone, to please come on the dais and take his seat. Along with this, I request H.L. Tabiyar sir, Kaushik Sarkar sir, P.K. Sishodia sir, P.B. Mandal sir, and R.R. Tiwari sir to come on dais. As we all know that Kaushik Sarkar, Inspector of Mines Occupational Health, is the main person who designed this workshop, who coordinated this workshop, who coordinated throughout the India to get the delegations and papers to present in this workshop. So with this, apart from that, after this day-long sessions, there is also a technical recommendations group discussions. So, for this, I request Shri Kaushik Sarkar Sahab to give just as a small brief on the recommendations of the committee. In the same time, I request Shri H.L. Tabiyar Sahab to please join us on the dais. Sarkar sir, please.
Good evening to all my friends. So I think all of us are equally tired as we are. So it was a really brainstorming session for the whole day and equally brainstorming when we were finalizing the recommendation. So finally we have come out with the recommendation part. Without going into the details of the workshop, we all are present here, we know how many people and what speaker and all. I'm not going to the I'm coming to the recommendations. Our first recommendation was adequate training facilities required to be created along the country, across the country for training of doctors in occupational health and ILO's classification of test radiograph. Central level institute, regional level institute, ESIC medical college and other research institutions should be advised to provide training in this regard. National Medical Commission is also required to be requested to include occupational health as a full-fledged chapter subject in the MBBS curriculum. Second recommendation is all the posts of medical inspectors, both in state and central governments, to be filled up on priority basis. Our third recommendation was well-equipped diagnostic as well as healthcare facilities to be created in each clusters of small and unorganized mines with the help of ESIC and district hospitals for facilitation of detection as well as treatment of silicosis and other notified diseases. In the line of the Rajasthan government, all other state governments should be advised to make a policy for silicosis and other notified disease. Our fifth recommendation was state government should be requested to provide the locations of the compensation commissioners district-wise for the entire state along with their jurisdiction. Number 6 was a facility of mobile van equipped with the X-ray and other investigative tools for occupational health survey can be created with the help of ESIC for silicosis survey in mines of unorganized sector. Our seventh recommendation was development of suitable training module and courses for training of mine workers, supervisors and officials in the mines. Establishing a center of excellence for silicosis and pneumoconiosis research at state and national level for development of dust cluster system and technological innovations to eliminate silicosis and pneumoconiosis from the mining industry. Our next recommendation was provision of automated and AI integrated health monitoring system at workplaces and maintenance digital record of employees' health data. Our 10th recommendation was development of national program for elimination of silicosis and pneumoconiosis NPES similar to National Tuberculosis Control Program, strict compliance of mining statutes of dust control measures by the mine management. Our 11th recommendation was to review the exposure limit for equipment-induced under and whole body vibration of ISO standards. 12th recommendation was the chapter of occupational health issues in mines should be included in the curriculum of mining engineering. These were the crux of what we have discussed today as a whole, and our recommendation committee included Dr. P.K. Shishodia, Dr. Rainaran R. Tiwari, Dr. Saroj Kumar Kumar, Dr. D.B. Mandal, Dr. Devashish Nyogi, myself and my two colleagues, Dr. N. Balasubramaniam and Dr. I. Satyanarayana. So this was all about what we have discussed today, what we have brainstormed today, and finally we have came out with
the crux of today's all the discussions and all the papers internationally. Thank you.
So we want to take the opinion of the House that whether we vote or we support this crux of the today's workshop. Okay. Thank you all. So at the end, I request Sarkar Sahab to give mementos to our participants and dignitaries. I request Sarkar Sahab, please come in between of the dais. I request Dr. Shankar Bamania, CMHO Udaipur. Please come forward. I request Dr. Rakesh Bhatnagar, District Tuberculosis Officer, Chittorgarh. I request Dr. Narendra Yadav, Deputy CMHO, Rajsamand. I request Shri A.K. Narwana Sir, Assembly Management, Udaipur. I request Shri N. Sridharan, LEO, CLC, New Delhi. I request Dr. Shriram Choyal, MO, LWO, Ajmer. I repeat, Dr. Shriram Choyal. I request Dr. Ravi Raj, State MO, RO, ESIC, Jaipur. I request Shri Vinod Kumar Parashar, Pharmacy Officer, LWO, Ajmer. I request Dr. Divish Kumar, Vocational Instructor, NCSC, DA, Jaipur. I request Shri N. Balasubramanian Sir, DGMS, Soma. I request Balasubramanian Sir. I request Shri I. Satyanarayan Sir, DMS, Ajmer Region 2. In this, I request industry partners who supported this event, Shri O.P. Rashtraji, Wonder Cement, Shri Pankaj Agrawal Ji, Shri Cement, Shri Naveen Aaron, Jindal Shop, Shri Radharaman, SZL, in the last, myself, Yatin Sharma from JK, and in this, I request Shri D. Jaisakar Sir, Director Mines, for a word of thanks.
Thank you, Dr. Sarkar. So, at the end of this first one-day workshop, and after all the brainstorming session, and it's very good to have a lot of doctors here to actually put their brains on and minds on this topic. I would actually start my word of thanks with our Honorable DDG Sir, Shri R.T. Matikar Sir, DDG Northwestern Zone. Under the guidance of Ujjwal Das Sir, DDG Sir has taken all the initiatives to create a very valid and sensible and a very multi-dimensional forum. And this is the need of the hour to address this issue. And I really thank him for all the efforts he has made and the directions he has given to make this national workshop a success. I would request everyone here to give a round of applause to him. After that, I would actually thank Dr. Sarkar. He is the actually man behind the whole theme of this workshop. So, and he is the person who has actually roped in one of the best speakers and the best minds who were here throughout the day. I thank him for his valuable inputs and his dedicated hard work for this workshop success. After that, I would actually, as you all know, we in DGMS have always strived for perfection. So, and this cannot be achieved without a teamwork. So, first of all, the team consists of the very highly knowledgeable speakers who are there among us. I would request everyone here to actually give a round of applause to the speakers who actually made this workshop a success. And of course, the doctors and other higher and senior management across the industry who have given their presence and contribution to this event. All the doctors, from state officials, from DMG, from CMHO office, from various Ministry of Labour departments like DG Fastly, ESIC. There is a lot of persons who have actually been involved. As I told, the whole idea was to involve a multi-dimensional participation, and DG Fastly, ESIC, NIREH, NIOH, these all have actually given their contribution to this workshop. I thank one and all of them. After that, I will even thank our Honorable Shaktawat Saab. I would request Shaktawat Saab to just come on the dais for a momento, please. I request Shri R.T. Mandikar sir to give a memento to our Honorable Union Leader and Representative, Shri Kalyan Singh Ji Shaktawat. Carrying on with this, I would just like to thank all the management, specifically the management who were honored by the organizing committee by mementos, but still I would like to name them, specifically the day in and day out efforts of our Wonder Cement Limited team under the guidance of Shri O.P. Rajpal ji, our JK Cement team under the guidance of Yatendra, our Hindustan Zinc team under the guidance of, I don't know, I think 4 or 5 people have actually been actively involved in this, so everyone. Our Sri Cement team, specifically the persons who are there, Sri Jindal Saw Limited, the Mine Safety Association of Ajmer and Udaipur region, and having said that, as you all know, the team behind these activities, they are all always off the screen. They are not on the screen everywhere. So the persons who have actually worked very hard right from the day one when this whole concept was conceptualized. There were a lot of people from DGMS like our staff officer Tom Matthew Saab, Satyanarayan Saab, Kateva Saab, Raghu Saab, JP Verma Saab, and Niranjan Kumar Saab, our Vishal Goel, Rajneesh Salvi Saab. I can keep on going and the name will never end, so I again request all of you to give a round of applause to everyone. Last but not the least, actually, I would really appreciate all the facilities provided by UCCI. For that, special thanks to our President UCCI, Mr. Mangilalji Gunavaji. Actually, the whole concept was very high profile, and it's not always that all the doctors come together in a seminar and discuss about occupational health. Mining being a very technical matter and occupational health being a very medical matter, so combining both is always a challenge, and this could not have happened with all the persons which I have actually mentioned. So thank you once and for all. Have a nice Christmas and New Year. Thank you.
किया